We are live.
Good evening, everyone. Welcome to this 9th episode of AIOS GuruSangam. Thanks to the steadfast efforts from Dr. Honavar in democratizing postgraduate learning and for creating a rich platform for teachers to share their vast knowledge. And lastly, thanks for making me a part of it. We have a rich panel of experts today. Dr. Lalit K. Nepalia from St. Francis Hospital, Ajmer. Dr. Rajan Gupta from Rajan Eye, Heart and Laser Center, Haryana. Dr. Rajesh Joshi from Ori Vision Nursing Home, Nagpur. Dr. Sabyasachi Patnaik from RGH, Rourkela. Dr. Sujata Rathod, Minto Eye Hospital, Bangalore. And Dr. Vandana Saroha from IQ Vision Private Limited, Gurugram. So without much ado, I'd like to proceed and request the first speaker, Dr. Preeti Srinivas Raghavan from Agarwal Eye Hospital, Hyderabad. She will be presenting on ICL Surgery's Pearls for optimal results. Dr. Preeti Srinivas Raghavan is currently the Regional Head Medical Services Gachibowli. She is Chairperson of Education Committee of Clinical Board of Agarwal Group of Eye Hospitals. She is a Senior Phaco Refractive Surgeon with prime focus on premium cataract surgery and complicated cataracts. Her achievements include securing state rank in higher secondary schooling. She's a gold medalist in MBBS from Stanley Medical College, Chennai. She's a batch topper in MS Ophthalmology from Arvind Eye Hospital and Postgraduate Institute of Ophthalmology, Madurai. She's also alumnus of IIT Calcutta, having completed her executive MBA in healthcare management from this prestigious institute. In her 19 years career post-graduation, she has performed over 25,000 surgeries, including a variety of cataract surgeries, anterior segment surgeries, and refractive surgeries. She has presented various papers and has been instructor in state, national, and international conferences, and has multiple publications in both national and international journals. I hand over the screen to Dr. Preeti Srinivas Raghavan for her talk on ICL Surgery's Pearls for optimal results.
Thank you. Thank you, Dr. Charita, for a kind introduction. I would first like to welcome you all to this session again. And I thank the panel of AOS who has given me the opportunity to be on this podium today with all the other dignitaries present. So I will be sharing my screen now and I will be speaking on the topic. I hope my screen is visible.
Yes.
And my audio is clear.
Screen. Yes, yes.
Yeah. So my topic for today is ICL Surgeries, Pearls for optimal results. And I have no financial interest. And I will be handling these 5 topics primarily. The first one is understanding about phakic intraocular lenses, ICL in specific, and ICL, as we know, are implantable collamer lenses. What are the indications for ICL I'll be handling? And then what preoperative things which we should do, like determining the correct ICL power. How do you size it for an ICL? How do you determine the axis of orientation, check the ICL receive and schedule the surgery? And how do you mark if there is a toric ICL? And also we will be handling about the intraoperative things which we will have to do during the surgery for getting an optimal result. There are a few points about post-operative assessment and troubleshooting, and very importantly, the importance of counseling. So going forward, as I said, I will be handling about the ICLs and specifically the phakic ICL or the posterior chamber phakic ICL, to be very specific. And ICLs, they were introduced by the Star Surgicals. The current models are EVO and EVO Plus. These are the monofocal ICLs which are present in India, which are available in India. But they've also come out with a multifocal ICL, which is EVO Viva, which is expected to launch sooner in India, but it is currently available in other few countries. And what are the indications of ICL? The EVO or EVO Plus are indicated for clear phakic patients 21 to 60 years of age with an anterior chamber depth of 2.8 mm or greater to correct or reduce myopia ranging from minus 0.5 diopters to up to even 20 diopters. So the EVO Viva lenses, as I said, these are in addition to the above, can also be put for pseudophakic patients and with or without even presbyopia. But the same thing holds good that the AC depth should be 2.8 mm or greater. And the EVO Plus and EVO ICLs are all intended for placement in the posterior chamber of the eye. And let's go into a little detail about the ICL material and advantages. So these are implantable collamer lenses introduced by Star Surgical in 1993. They are 100% biocompatible, soft, flexible gel lens. This patented material is made up of 60% of polyhydroxy ethyl methyl methacrylate, HEMA. Water content is around 36% and benzophenone 3.8% and 0.2% of porcine collagen. They are a safer alternative to refractive lens exchange, which carries the risk of retinal detachment and loss of accommodation in a very higher power group. So the posterior chamber intraocular lenses have been conventionally used for high degree of refractive error or when corneal refractive surgery is contraindicated. So what's the main advantage? Reversibility is the main advantage. No additional space is required to handle it, like having a specific refractive surgical machine. And also, we have only very minimal additional instrumentation which we will be handling going forward as a requirement for doing a implantation. And these are all FDA approved materials, and this got an FDA approval in 1995. So the main advantage is a completely reversible procedure, and the material is completely biocompatible, as I told. And we don't require a huge effort from our side with respect to the capital, but definitely training surgically is very important. And then we just, before going on to the specific surgical entity, I would like to say this also had an evolution like any other IOL, intraocular implantation implant. So the ICL is basically a rectangular one-piece plate haptics design. I'll show you in the animation which will be coming. And this is plano concave. And we are currently, from the Visian ICL V4, it has been commercially available since 2011 to correct myopia. The toric version was FDA approved in 2018 to correct or reduce myopia with astigmatism. Both lenses are available in 4 lengths. This is very important because sizing will depend upon your knowledge about what is available. So we have it at 12.1, 12.6, 13.2 and 13.7 mm. And these lenses are 7.5 to 8 mm wide. And the V4C or the EVO model, it features a central port or a hole of 0.36. It's called as a case aqua port, meant to eliminate the need for Nd:YAG iridotomy or iridectomy that was required in patients who had the previous models, which did not come with this small opening. The port is meant to allow the physiological aqueous humor circulation. The lens also has an ultraviolet absorbing chromophore. So the EVO or EVO plus ICL model V5 is a recent addition, actually, followed by EVO Viva based on the same chassis and expanded optic design. So the optic design has been, the optic size has been slightly increased. The EVO Plus and the EVO Viva actually has a larger optic diameter up to 6.10 and can be used to correct residual refractive error after cataract surgery as well. That's why I said we can also implant it in pseudophakic case, as well as novel 360-degree micron port in the center of the optic. And the EVO and EVO Plus ICL also has a toric version. As I said, they were both FDA approved in the United States in March 2022. There have been a lot of published studies which have demonstrated the safety and effectiveness of these models for correction of myopia and astigmatism. So the Star EVO Plus Viva implantable collamer lens, it has an aspheric optic referred to as the extended depth of focus implantable collamer lens. This is a new thing. Most of us will be aware of the EVO and the EVO Plus model, which we are all using. I just wanted to give an additional information about this EDOF ICLs also, which are available abroad for correction of presbyopia as well. So let's come to the preoperative evaluation, which is very important for any surgical technique. So we need to do a complete ophthalmic examination, including an uncorrected distant visual acuity evaluation, corrected distant visual acuity, a good refraction, manifestation, cyclophagic if possible, a white-to-white measurement, slit lamp biomicroscopy, intraocular pressure measurement via Goldman appellation, gonioscopy, corneal evaluation, including central corneal thickness measurement, endothelial cell count, if wherever possible, if there is a doubt, definitely then, as well as the antechamber depth. A very important thing is dilated retinal examination and evaluation for presence of retinal tear or lesions. I hope I'm audible and my slides are clear. If there is any difficulty, please let me know. Am I audible?
Yes.
Yeah.
Yes,
So
yes, yes. Go ahead.
Yeah, thank you. So this is a picture which shows us how we evaluate the patient completely. So you take a normal autokeratometry reading, and then you have to also see their PG power. What is the current prescription to know what will be their acceptable refraction, and what is their, very importantly, what is their unaided and the best aided and pinhole vision as well. So we do an auto refract AR, and then we also do a dilated AR, and then we do a dry refraction, and then all the other parameters like the appendages, the conjunctiva, everything is important when we are doing planning for an ICL. And we do not want too much of a dry eye. If there is a dry eye, we need to treat the dry eye. That's why the ocular surface examination is very important. We have to look for cornea clarity. Any opacity will interfere with the vision, which we promise post-operatively. And the pupil as well is very important, because these lenses, as I said, will have a small central hole, which we generally align with the center of the pupil as well. An ectopic pupil or a irregular pupil or a improper or a non or a antechamber which is not anatomically normal might not be an ideal situation for taking up for an ICL. So we need to see all of these parameters, and also what is the photopic and scotopic, if we are able to note down, like how we note down in LASIK or a refractive surgery, is very important, so that post-operative glare is also attended to. So, and then we do an indirect ophthalmoscopy. It has to be done. And why I'm showing this paper is, as much as we do, documentation is very important in an era where medico-legally we need to be very careful. So all the things which we do need to be properly documented as well. If you have an EMR documentation, well and good. Otherwise, we need to document in the paper we have with us. And then the advice we also routinely do, we have to do a good topography. If you have an op scan, we do an op scan. If you have a pentacam, we prefer a pentacam. After that, we need to measure this white to white, because the ICL sizing will be depending on this. So what you see in the screen is a digital caliper. Digital caliper is more accurate. So we measure from the clear cornea to the clear cornea, the white to white. If you have a better instrumentation or a better digital measure which is available, you need to always remember, for the white to white reading taken from the following device, the caliper clear cornea reading are expected to be smaller. So what you measure in the caliper and what you see here might have a small variation. We need to keep these parameters also in mind when we are ordering or telling that particular person what is the what do we expect, what is the white to white we are going to give them finally on the paper when we submit for a calculation. So lens sizing, the nomograms are available from the Star Surgical to select the correct size based on the white to white measurement at each chamber depth measured from the corneal endothelium. This we need to remember that we are going to measure from the corneal endothelium to the crystalline lens. Accurate sizing of the lens is important as it affects the vault. Vault is very, very important. The most reliable in my experience of so many years, I feel it is OpScan 2, but nowadays we have Pentacam, so we need to put that little adjustment factor. And I also rely more upon my digital caliper. And while using the digital caliper, it is better to make the patient lie down, do it under magnification. If possible, inside a theater is the best way to do the measurement. And we have to do it under topical anesthesia with the patient looking at the light above. And the size of the ward, what we should ideally have after the surgery will be 250 to 750 microns. A larger lens is associated with a higher ward. So that is why sizing is more important. And a ward which is less than 250 microns, what happens is the lens will touch the lens, touch the crystalline lens, and you will have a higher risk of developing an anti-subcapsular cataract if not done properly. So sizing is very important. A ward greater than 750 micron risk, it will lead on to pupillary block glaucoma and crowding of angle with possible iris shaffing and resulting loss of pigment dispersion, which will come over the ICL, and that will also impact the clarity of the patient. So ICL sizing is very important. So what you measure and what we give to the company is very, very important when we go ahead with the ICL sizing. And as I said, they have a nomogram. The ICL power calculation is performed through the online calculator provided by the modified vertex formula, which is provided by the Star Surgical. The power calculation is based on several variables in the formula, like preoperative, manifest spherical, and encyclopedic refractive error. So we will be asked what is the refractive error we need to correct. We need to aim for a ametropic correction there. And what is the keratometric power, the corneal thickness, the horizontal visible iris dimension, and the central antechamber depth. The ACD is measured, as I said, from the corneal. Generally, when we say ACD, if you see the optical biometers, it will be from the corneal epithelium to the crystalline lens. But when we go for an ICL sizing, we need to remember that we have to measure the ACD from the back of the cornea, that is the endothelium. And thus, we need to subtract the corneal thickness ideally. So if you look into an optical biometer, we should not be going ahead with that, but we should look into the pentacam, which will give us the measurement from the endothelium to the anti-lens capsule. So this is what I wanted to show you. This is what we give. So we also will have, see, everything we need to correlate. So you have to correlate what the manifest refraction of the patient is. We have to correlate what we are getting after the dilated subjective. And we need to have our ametropic refraction in mind as well when we are giving this particular thing to the we will have to submit a form, like we have a pre-operative set form wherein we'll write all these parameters and send it across so that they will calculate and send us this sheet. So in the sheet also, we need to be very careful. We need to check what is being said, whether the names of the patient is matching. So these are very important for optimal results because there can be sometimes a mismatch. So we need to check the name of the person, the refraction, which eye are we looking at, and whether what we have suggested is what is there on the paper, and then choose whether the lens which they have suggested to us would be the right one for our patient or not. So you need to know that these are the sheets we will generally see when we go up for an ICL surgical thing. And then if there is a toric ICL, we will also be given what axis we need to rotate the lens after the horizontal placement. As we all know, when we approach a patient from the temporal entry, we will be inducing lesser astigmatism. So I generally prefer only incision at 180 degree, and it is generally recommended that way as well. So mostly what is given will be the rotation after an horizontal implantation. That is what is given in this paper. And this is another thing which is again showing us that they say rotate lens counterclockwise after horizontal implantation. And it will also be mentioned because we are using the V5 model that you don't have to do a pre-PI. Earlier when we used to do the ICL, we have to do a pre-operative PI, wait for the inflammation to settle. Now that problem is not there. So we need to look, and this is the pre-operative marking. So if suppose the patient is for a toric ICL, this is how we mark. We make the patient sit down on I prefer a marking with in the slit lamp because I've found that it is quite safer, quite easier for the patient and for the doctor. And we can use the axis which is given in the slit lamp itself, like how I just did. First, I marked a 90, ask the patient to look straight. You can use a fine tipped marker and ask them to look into the light. If you see in this display, which is there, very fine line has to be projected on the cornea. The eye has to be moist. So we ask the patient to blink. And then you mark the 0, 180, like how I'm marking. So once you mark the 0, then you mark the 180 as well. So this generally, as I said, done under topical anesthesia. The instrument necessary for marking, you can have a cornea marker, a slit lamp with a grading ring, and you also note down the anatomical reference point for the eye. So that is about this. And this is how it will look. It can be much finer as well, but sometimes faint mark goes off. So I have a tip which will say that you put the marker and then you rotate a marker a little bit with a little force so that the stain remains even when you where after you put the dilating drops. Generally, it is told that you need to mark when the pupil is non-dilated, and then you dilate, and you see the mark has to remain till you take the patient into the theater. And there are some other markers also which are told. This is a bubble marker which is used for a toric marking. And why I'm talking about astigmatism is we see a lot of patients with astigmatism also. So in my ICL practice, almost like 20% will have a minimum will have a toric or astigmatism, and any astigmatism above 0.75, it is mandated by star ICL that it is better corrected for a better optimal result. So that is why I'm talking about the toricity as well. So this bubble marker also can be used, slit lamp marker. The various markers which are available for marking pre-operatively, means in the pre-operative area, and also during surgical implantation. So as I said, once we know that these are the dioptric powers which are available, we also have a hypermetropic correction, but generally it is, the hypermetropes have a very small AC depth, so it is not much recommended as well. So it is minus 0.5 to minus 18 is the power which they have made available mostly. And then, so this is and one other point. So now we have seen the mark, we have seen the examination, we have seen the assessment, we've seen the indication. Now we have given the things to the company, and we have got the lens in hand. It generally takes some time for us to get the ICL to us, and now let's go on to the surgical preparation. So why I am showing this video is, the patient should not be prepared unless we load the lens. The lenses are very friable. So initially, in fact, we need to have a dry demo outside. So whenever you plan for an ICL, any good anterior segment surgeon can definitely do an ICL surgery if trained appropriately. So that is very important. And this is how it will be. So you have to prepare the patient only after you load the lens. That's why this is given. So the loading of the lens, so this is the injector. This is a small tip which will come. This is very important. So the injector and the tip plunger, we call this, and have to be set properly. There will be a small knob on that. And then you see whether it is locked well and it is good. And always keep everything a little moist. So I dip it in the saline. And then this is just to show the loading of the lens. So after you load the lens, we have to withdraw this plunger, and then I'll show the loading of the lens in the next picture. And you put it inside. The cartridge is placed inside the injector, and it is locked well. And then you have to gently push it a little bit to see whether the movement is free, but not too much. The lens has to come to around a 2 millimeter, like 1 millimeter from the tip, and you keep it secure. And so this is just to show what we do. So so this lens, I generally prefer handling only with the soft tip before putting the tip into the injector. So very importantly, I will show you there are 2 orientation marks which have to be placed. I always ask them to remember driving. So your right hand should be up. So out of the 2 marks, always remember the leading haptic mark should be on the right side. And then you have to orient well, place it properly. You can use a very gently your McPherson's if possible. But you see to it that all the 3 holes are central and aligned. And then under high magnification, this is an ICL forceps which we use, and you need to gently hold till the tip, and then you pull it. So as you pull, you need to withdraw also. There should not be too much force. Very important with ICLs are the loading, because you may tear up the lens if you are not careful about it. So you orient yourself. As I said, you need to sit temporarily. You make an incision. Temporarily, you extend it a little bit, and then make sure that the extension is because the tip has to enter into the antechamber. And then this technique is very important. You push and you wait. You push and you have to wait. It will unfold, and you also have to make sure that the leading haptic, that orientation mark, is onto your right side. If it is not there on the right side, you are wrongly pushing the ICL, and you will be ending up in trouble. So this one tip I wanted to tell, that you have to extend your tunnel a little bit, and you have to use a push and a pull. Push, wait for it to unfold. And then use a very gentle and a soft tip And then when you're tucking the ICL haptic, it has to be a pull and a release. You can see how the movement I'm doing, it is a pull and a release. And you put adequate viscoelastic as well. And so that there is no damage to the endothelium. And you orient it if it is a toric ICL. So these are the few tips. This push, wait, and this pull and release. If you remember, you will have a good ICL post-op and good ICL results. You can use a Simcoe cannula or you can use a IA, but you need to be very gentle while doing all these maneuvers because we don't want too much of a push or too much of a imbalance when we are doing an ICL, because we don't want the ICL to touch the crystalline lens. So all your movements have to be very, very gentle. So this is a marking, a round marker which I've placed, and then I wash it gently. And then generally we can put a pilo if you are not confident earlier in your earlier stages. And through the sentry port, we can remove almost all of the viscoelastic. So try removing all your viscoelastic. Try not, see, I'm tilting it down and I'm removing the viscoelastic, trying to remove the viscoelastic. Try not to touch the center. So this is just when everything goes very smooth. Okay. Sometimes what can happen is you can have when you are injecting the ICL, you may have problems. So there are some tips which can help you to prevent those problems as well. So this is what I was just showing you all. So after a gentle AC wash, if you want, you can suture. See, as I said, you can extend the port a little. So in the earlier stages, do not hesitate to suture. You can always release the suture later. So you need to be sure that the AC is well formed. So this is just a video to show that what happens if it turns against, you can retrieve it back. For the want of time, I'll go to the next slide. So this is another one where I would like to show you about few things. So this is, as I said, this right side up. So this is the ICL. And as I said, understand, load step by step. See the AC depth. This is endothelial AC depth again. Just like a take home, I'm repeating it. And then you have to see the white to white. And then you need to understand the ICL. I had told you that this has got 2 orientation marks. And then it will have you should not put it other way around. It should be right side up. You have to remember this. And then the convexity should be maintained up. That is very important. And it will also be up when you put this properly. And these are the edge holes and this is the central hole. And you have to remove any air bubble before you load. And this pull through method is what I showed you just before. And these are the 3 marks. You always have to remember these 3. There are 3 points and 7 position we say. You always remember that your hand should pronate or supinate. Your wrist movement should be very, very gentle so that it lands up right. So this is one position where you have everything, this cartridge hole, these 2 ICL holes. It can be on the either side because when you pull through, it might rotate as well. So we need to be very careful with that. And this is a leading, trailing and cartridge lock. Always keep a watch. So it needs to go this way. So that is what we are trying to show. Make an incision, push it, and that right side has to be up. And if there is that difference, if it is not in the center, then you need to rotate accordingly. So this is both axis and edge holes are a little different. So you see the movement, you push and then you pronate or you gently rotate your wrist so that anyway it ends up only with the right leading haptic. The right leading haptic only has been, the hole should be on the right side. That we need to remember. So this is another one where we will rotate it to the anti-clockwise. This is clockwise rotation. You have to just see that. You have to have that in mind that you will need a rotation if the 3 holes are not in the straight line. So this is what I showed you earlier. This is just a zoom view of in another case. So this we saw. So post-operatively, what we'll see now, we have done a good surgery. We know what has come. If we had a problem, we have to take it out and reload, and we have to inject again. So we need to be quick in everything, because sometimes what happens is the pupil starts shutting down. So do not hesitate to use a little bit of a intracameral dilating agents also if you feel the pupil is shutting down, by which I mean the pupil starts constricting. So what we see afterwards, we see whether the refraction is fine, what is the IOP, that is very important, and the vaulting. So this is the vault. Only thing is we should not terrify the patient, whatever has been happened. So don't try to assess the vault in the very next day. This is mainly for us to keep a follow-up, wait for the patient, always check binocular vision first. If the patient is happy, then go for a uniocular check. After one eye surgery, you can do the other eye the next day. That is much safer. The patient will also be comfortable, will have a confidence in what you have operated. And then this measurements and all can come a little later. You can do it after 1 month for your follow-up. If there is an issue, or if you have any problem, like there is an increase in IOP, then you can go ahead and do all this. But these are important for us, and we will document it at least after a month so that we know the things have gone well. Post-operative management is like any other intraocular surgical management only. You put them on a steroid and antibiotic. One thing we should remember is we are doing it in very young people. So steroid response is very much possible. So be aware of that and check it appropriately. The post-operative regimen also remains the same. Generally, we say check the 1 day, 1 week, and then 4 weeks after surgery. Subjective refraction for distance and near is obtained. Autorefractometer you can avoid. And just a word before I finish, because I was talking about ICL, you also have something called as an IPCL. I do not have much experience because most of my cases had been ICL only, but to cover the topic, I wanted to say that there is an IPCL as well, which is an Indian make. So the take-home points which I wanted to tell is, as I said, you can always have some troubleshoot. So you should be prepared. You should make your patient also well prepared. So your patient counseling is an art to be mastered, because the surface refractive surgeries can be counseled very easily. Patient will understand, and it can be done at the same time. When you do an intraocular procedure, we need to tell them, but tell them very subtly, and tell them what they can expect, how and why we are doing this. You have to tell them that your thickness had been lesser, or whatever, why we are choosing the ICL has to be correctly communicated to the patient. And if you do that, the patient, you have a lot of chance of acceptance with that particular patient. So generally, I practice under promise and over deliver. And also, whenever you put a toric, you indicate there may be a need for rotation and need for stability of the ICL, and do it subtly, so that you are safe. At the same time, the patient understand. The ICL sizing and IOL power calculation is very important. Appropriate choice of ICL, appropriate ICL implantation follow-up care is important, and you have to always be very bold. Surgeon have to be bold. And post-operatively, we need to treat the patient. This is for all surgeries, I say. Treat the patient and not the readings. So you need to treat the patient and see what the patient wants and what they require afterwards. And as I said, we do say that ICLs are for patients where refractive surgery surface is not an indication. I would also say it in a different way, that if we are confident, as it is a very good procedure, we can also try it in patients. From my lowest power had been around 2, because the patient had a very less corneal thickness. But I've also done ICLs in patients who had good corneal thickness, very high power. So the surgical technique has to be mastered, whether we are doing it for any patient. Saying that, I would like to end my talk for today, and I really thank the panelists who have given me the opportunity again. Thank you very much. Thank you, sir.
Can I put up a few questions?
Yes, sir, sure. Thank you. I'll stop my share.
Dr. Preeti,
Yes, sir.
I congratulate you for a wonderful presentation. You have talked A to Z about ICL, right from pre-operative evaluation to take-home message. IOL surgery in past few years has taken a leap in our country, and even we have few very good centers in Rajasthan also. One thing I wanted to know, when you are doing pre-operative counseling, this is I'm talking about for the interest of the PG students and young ophthalmologists who are keen to do their fellowship in refractive surgery, and they are viewing this program, they are watching this program.
Sure.
What do you tell to the patient that worst come worst, if there is a failure, another option is available with the patient. Number one. Number two, you have rightly said that it's a reversible procedure, but still, what cases you would like to choose for LASIK or this refractive surgery, or you will say no, this case is absolutely fit or indicated for Vivo ICL? Because there's a big debate what cases are to be considered for LASIK and what cases are to be considered for Vivo ICL. Of course, I would like to have few more comments from you for these Vivo Vivo also, because till yesterday they were in pipeline, but today they have come in practice in few of the countries. So please cover these 3-4 points for the sake of our PG students and young ophthalmologists.
Thank you so much, sir. I would like to answer one by one. The worst complications could be like, first thing is that generally we should not have a residual refractive error. That is our first motto when we are planning.
Quite true.
But in worst case, if we end up with a refractive error, we have to see whether we can add on a correction, but that we need to tell them afterwards only, not immediately. The second thing also, post-operatively, I would say the things will be they may develop glaucoma, which we see sometimes if the ICL sizing is not well, or in patients where they've operated outside, I've seen them coming with glaucoma intractable also within a month or so because of whatsoever be the reason. So we need to be equipped enough to handle the glaucoma part of it, first medical management, and then if we feel that there is a lot of problem, we may have to even counsel them for a removal of the ICL and alternate surgical procedure. Second thing is, if there is a problem during surgery like a lens touch, we can expect a cataract, or if the vault become less, we have to expect for cataract later. But we may not be very comfortable counseling this immediately, but we need to keep a watch, and if required, then we have to remove the ICL. I have done many implantation for people who come from outside. Mainly the problem is anterior subcapsular cataract. So maybe it can come after 5 years, after 6 years. So we should be able to tell them that we need to remove that lens and do a cataract extraction and put an intraocular lens, which will suit the patient. These are the things, if I'm telling about the post-operative refractive residual errors and complications which occur due.
Quite true.
Yes, sir.
So
Yes.
Advantage of this Evo ICL over LASIK surgery. What cases you will say no? You must go and undergo Evo ICL only.
Yeah, the definite cases will be those who do not fit for refractive procedure, like thin cornea. Anything less than 470, I will not touch the cornea whatsoever.
True.
Whether even the corneal pattern is good and if the powers are. And the second thing is higher refractive errors, like more than 7, my choice would be definitely an ICL. And if the corneal pattern is even a little not normal, as in the patient has got a very steep cornea or very flat cornea, which will cause a glare after a refractive procedure, my choice would be ICL. But and if the patient has adequate time, and definitely if the thinning and all is there, I will definitely tell the patient about ICL only. So the definite no for refractive surgery are the 3 things which I had mentioned. Corneal parameters.
Very nicely covered, Dr. Preeti.
Thank you so much.
Very elegantly covered most of the points, and I request from the panelists any other inputs regarding how do you take if there is a mismatch between the crux of an ICL is always the measurement and the preoperative planning. So how would you deal with, suppose there is a mismatch between the subjective refraction and the cycloplegic refraction, and how do you deal with differences in the white to white? Which machine is your go-to machine for the calculation?
Yeah, so hi, hello everyone. So yeah, congrats, Dr. Preeti. Quite an exhaustive topic which you've covered up very nicely. Yeah, so you see, yes, recently ICL trends have increased because we see that, it's like a good choice, it's a safe choice, it's like you said, it's reversible. And also, with high errors, the chances of the quality of vision is much better with ICL. But of course, because we are doing it as a cosmetic procedure, I always tell my fellows that, your threshold for complications and all is very low here because the patient's expectations are very high. You're dealing with young patients. So yes, first thing for ICL, like Dr. Charulata is asking, usually we go with the subjective refraction always. And what I've seen is, with a good subjective diffraction in my last 20 years, rarely have we had a refractive surprise. In fact, the most common problem that we are still facing with is the vaulting issue. Because despite all your efforts, you will have surprises where the vault is less, the vault is too high. So in fact, that's the only thing because again, whatever we might say, I think we still have not mastered the white to white. Nowadays, we have more formulas, like that lasso formula where you are incorporating ASOCT also. But yeah, many people may not have ASOCT. That doesn't mean that, you cannot do an ICL. So yes, still vaulting is a big issue. And another thing, when the fellows are planning an ICL, I tell them is firstly get acquainted with the product, what is available to you. You have by Star, you have by the biotech company, you have two more by the eye care company also. Get acquainted with, what is the corneal limits it allows, like below 10.5, below 30, more than 13 mm. So mostly it's like in a normal anatomical eye. Then acquaint yourself with the products, what is the power available. Then will you be confident enough in ordering an ICL? So yeah, some these points are very important. Of course, the good thing here is the learning curve is very low because there really aren't very many steps involved in this. But like I said, because it's a cosmetic procedure, your responsibilities it increases multifolds. It's not like a cataract where a complication, a patient is more accepting here, patient is not accepting. So yes, these two factors you need to tell them that yes, despite everything, we will check your vault later on and we need to see whether the lens is I use the term like loose and tight. I tell my patient, we will have to check post-op whether the lens is loose or it is tight. And accordingly, we might have to, like a tailor adjusts, we might have to make adjustments because a lens which is sitting correctly will, is with least complications. So yes, I think we could just go on and on talking about ICLs. Yeah.
Another
So
question that I wanted to bring up, and if the other panelists could also pitch in, is what is the worst complication that you have had? For example, we've seen all seen steroid responders, and very high myopia is associated also with some glaucoma. Family history of glaucoma is already there. So, if you could share some post-operative complications?
steroid response is generally not difficult to manage. Like initial 1 or 2 days, if you have high IOP, you could have a factor of retained visco. And usually, anyway, steroid response will not start in 1 or 2 days. So normally, when the patient comes for the first week follow-up, usually it's around that time, or even before that, maybe third or fourth day, you would know, whether the patient is steroid response. So just be on an look out for that. And generally, usually, then I shift them from Predfort or this to a lower steroid, which works fine, and then add a, IOP controlling drug for some time. So yes, if you have to look out for that. Generally, steroid response is not difficult to manage. Yeah.
So, very rightly, Dr. Nipalia, would you want to add to that, please?
I thought few of the
Operative
cases,
complications.
I thought some of the cases still they, show a little rise in intraocular pressure in early post-operative period. So it is safer to put a patient on some anti-glaucoma drops for a week or two. That's all. Otherwise, I think Dr. Priti has done a wonderful job. Talking A to Z about ICL. Compliments to her.
Thank
Dr.
you.
Rajesh and Dr. Rajan, are you there? Would you like to
Yeah,
add any additional
yeah,
points?
yeah, I'm there. Just 1 or 2 points as far as post-operative complications are concerned. My concern immediate post-op is the anterior chamber reaction and the high rise of the pressure. That is the one thing. I have seen 1 or 2 patients having anterior chamber reaction, and we had to give them frequent steroids, dilating drops, and systemic steroids as well. That is the main concern because it's difficult to wash away or clear all the viscoelastics from the anterior chamber. I just want to ask Preeti,
Yes.
do you have any experience regarding implanting IOL under BSS? Because if you have implanted like under BSS, that will, in fact, there won't be any problem of viscoelastic inside the anterior chamber.
Yes, sir. I have never attempted implanting ICL and BSS. but I have done a lot of IOL implantation under BSS. But ICL, the fear of touching the endothelium or the lens is more for me. So I would rather like try and remove the visco as much rather than risk putting a ICL under BSS.
Yeah.
So I have never done so.
Okay, and the one difference I find between the IPCL is that the advantage with ICL is they provide only one lens. And if that breaks in between, then there is a problem. You have to postpone the surgery. That is not the case with IPCL. They usually provide two lenses. So recently, it happened to me that right upper haptic got broken away, and I could not see the leading whole of the haptic. So I had to postpone the procedure in between. I had to remove, and then I had to order the lens again. That is the one problem with ICL. Otherwise, ICL is a fantastic surgery.
Yes. Very
Anyone,
important.
excuse me, ma'am, any of the panelists would like to comment about any case they might have come across of TAS after ICL surgery?
Yeah, Dr. Rajan wanted to say something. Dr. Rajan, please go ahead.
Yeah, yeah. I had come under one case of TAS after the surgery. Secondly, the patient has an immediate rise of intraocular pressure, severe inflammation in the eye. And I had to put the patient on the oral steroids and frequent dilator. I had to dilate the pupil with atropine, and IV mannitol had to be given. But the third day, the patient was fine and started recovering very well. But that was for only one day. And I have one question to ask to ma'am. Whether you would like to treat a topographical cylinder or a subjective cylinder, which is a toric ICLs. Sometimes there is a discrepancy between the subjective acceptance of the cylinder and the topographical cylinders.
Yes, sir. But I have seen such discrepancies. That's a wonderful actually question. Even many a time we have this doubt what to treat. But I believe in the subjective refraction of the patient mainly. So I go with that because sometimes what happens, the lenticular astigmatism might be correcting this might be correcting the corneal astigmatism, and that's why maybe the patient is accepting that particular cylinder. So I would like to go with the refraction only, and I had a pretty good results. I've never had a touch wood so far. I've never had a refractive error residue as well so far. So my choice would be manifest refraction only.
Sometimes the patient have a higher refractive error more than -8 diopters. Sometimes you are in a dilemma whether to go for a cataract surgery, whether to go for an ICL or a refractive surgery. What will be your choice in that case? And the patient wants a LASIK done.
Please repeat, sir. I didn't get the question.
If the routinely we say more than -8 diopters of myopia, you will go for ICL. Sometimes the patient wants the refractive surgery and he is insisting upon and for LASIK surgery, and the patient is fit for the LASIK surgery. What will be your choice of procedure for in such cases?
So, like if we have the best of the machines, wherein we have the tissue saving as well, and we are confident that the thickness is very good and that the curvature of the cornea is very good, we have good RBT also. My first choice, even if it is above 8, will be Smile, basically Smile Pro. I do not prefer PRK above 7, even with mitomycin, because we have seen some haze after that as well, if the post-operative regimen which we advise is not followed. So Smile is possible up to 10. I have done some cases also and they give a good result if the thickness is good. But anything less than 500 microns, I will not touch Smile or do any flap procedures. And anything less than 470, my first choice will be definitely ICL only. So I consider the combination rather than only the power. So -8 will not prevent me from doing a good refractive procedure with a good RBT if they have a good RBT and a good cornea. So, and anyway, it is extraocular. So,
In the
Any
interest
special
of time, I
last
request.
and any special comment about AC depth in relation to ICL surgery, Dr.
yes,
Preeti?
sir. Very, very important thing which I would look into is the AC depth, definitely. Because anything less than We were trained with 3 basically. We used to always feel that 3 is very safe. Up to 2.84, 2.8 I do, nothing below that. I will not even take a 2.79 even on repetition of ACW because I will not do so.
Agreed. Thank you.
Thank you,
Thank you
everyone,
so
for the
much.
wonderful discussion. In the
Thank
interest
you
of
so
time,
much
we'll move to
for
the
the
next
opportunity.
presentation. So our next presentation is on preoperative cataract surgery evaluations by Dr. Indu Pandey. Dr. Indu Pandey is MBBS from BRD Medical College, Gorakhpur, MS Ophthalmology from LLRM Medical College. She was awarded the gold medal for best resident in ophthalmology. She's completed her short-term fellowship in glaucoma from Bombay City Eye Institute and Research Center, Mumbai, and she's currently working at Jagjeevan Ram Hospital, Western Railway, Mumbai since the last 15 years. At present, she's mentoring 3 students in PG Ophthalmology DNB curriculum and has a special interest in topical phacoemulsification, premium IOL implants, glaucoma medical and surgical management, retinal diseases, and VR surgery. She thoroughly enjoys teaching and learning. I request Dr. Indu Pandey to proceed with her presentation.
Thank you, ma'am, for the kind introduction. I shall share my screen. Is my screen visible?
Yes.
After the highly technical talk by Dr. Preeti, I'll come to a very basic topic presentation, that is preoperative cataract surgery evaluation. Today, cataract surgery is a therapeutic as well as a refractive procedure with truly outstanding outcomes. Though there are a number of reasons for this healthy scenario, a systematic and comprehensive preoperative workup, which includes identifying any ocular and systemic comorbidity, is essential for surgical planning and counseling on visual prognosis. I have divided my presentation into 4 parts, which includes the history, including the ocular and the systemic history, the clinical examination, followed by the ocular measurements, and then ordering suitable laboratory investigations. To begin with, ocular history. So here we see that history of present illness is the prime reason for which the patient is coming to us. And this in most of the circumstances is diminished vision. We need to know the duration of visual decline, whether it is for distance, near, or for both. Also, we have to see if it is improving with best refraction or not. We also need to ask the patient about decreased color perception, glare in bright light, if there are any halos around light, and if there is worsening during different periods of the day. At times, patient may also present with monocular diplopia or polyopia. Questionnaires such as the Visual Function Index 14 or the shortened version VF8R were designed to assess functional impairment in cataract patients. Now here we see that while the clear lens forms a clear image on the retina, but a cataractous lens causes scattering of light, resulting in the formation of a hazy image. Now, depending upon the location or type of the scattering can produce not only the vision, hazy vision at all distances, but also give rise to various phenomena like glare, halos, and starbursts. And all these lead to limitation in day-to-day activities of the patient. Among the important cataracts, the nuclear cataract we know causes a myopic shift. Say if a patient is coming to us with mild nuclear sclerosis and with a refractive error of -2 diopters, and the patient turns up some 3 to 4 months later with advanced nuclear sclerosis and a myopic shift of -6 diopters. So these nuclear cataracts present with myopic shift, and distance vision is affected more than the distance near vision, and there is difficulty in nighttime vision. As far as the PSCs are concerned, they affect near vision more than distance vision. There is greater disturbance in brighter illumination than in dim light. There is disabling glare and symptoms of daytime glare. This table has been taken from American Academy of Ophthalmology textbook, Lens and Cataract, which shows the major types of cataracts with their growth rate, and their effects on glare, distance vision, near vision, and induced myopia. After history of present illness, we come to the past history, past ocular history. We have the history of trauma, inflammation, amblyopia, strabismus, glaucoma, optic nerve abnormalities, or retinal disease might affect the visual outcome and change in surgical approach. For example, presence of active or even quiescent uveitis for that matter, with sequelae like fibrin membranes or posterior synecdoche may require perioperative systemic immunomodulation to achieve remission or minimize postoperative inflammation. Similarly, a family history of retinal detachment or a history of retinal detachment in either eye of the patient is a risk factor for postoperative retinal detachment. So patients should be counseled accordingly. Past history of glaucoma would require optimal control of intraocular pressure prior to the surgery. Also, in the current scenario, the surgeon may consider combining any of the minimally invasive glaucoma procedures like KDB goniotomy or bent angle needle goniectomy along with cataract surgery for better control or better optimization of glaucoma. If the previous records are available, it is very important to have a look at that also. And if the patient has undergone any previous laser vision correction, some additional measurements may be required. And amidst all the history taking, an astute clinician manages to elicit the patient's expectations from the surgery. Now we come to the systemic history or general health of the patient. Systemic evaluation is critical for the overall health and well-being of the patient. It is important to achieve optimal control of all medical problems, especially diabetes mellitus, ischemic heart disease, COPD, bleeding disorders, or adrenal suppression due to systemic corticosteroid use. The ophthalmologist should also be aware of the drug history, especially regarding the use of immunosuppressants and anticoagulants. And we should specifically ask the patient about the use of alpha-1 adrenergic antagonists, as for example, tamsulosin, silodosin, and prazosin, which are used frequently in geriatric population for control of hypertension and for the management of benign prostatic hyperplasia, urinary incontinence, and urolithiasis. Because these medications are associated with intraoperative floppy iris syndrome, which is characterized by intraoperative progressive miosis, iris billowing, and fluctuations in the anterior chamber depth during surgery. So if the surgeon is not aware of these things prior to surgery, then this may gravely affect the outcomes of the surgery. Besides that, there are allergies, adverse reactions, and sensitivities also, which must be documented. It is always also helpful to assess patients' ability to cooperate. If there is any deafness, if there are language barriers, if there is dementia, presence of head tremors, or severe kyphosis or scoliosis, and if there is orthopnea, like if patient would be able to lie down for a good 15 minutes to half an hour for the surgery, etc., because these may influence the choice of anesthesia and the surgical plan. In the social history, we need to inquire about the patient's occupation, which would decide upon the kind of lens implant which you would offer to the patient, the lifestyle, and any possible dependencies on smoking, nicotine, or alcohol. Family history also should be included, and the family members should be inquired about this. Now we come to the measurement of visual function. Visual acuity should be determined for both distance and near, and a careful refraction should be performed to arrive at best corrected visual acuity for both the eyes. If the patient has a dense cataract and he is not able to read any of the charts which are available, he must be tested for perception of light and projection of rays in all four quadrants. This gives the proxy of the gross health of the retina. Now, there are various visual acuity charts which are available. However, the most commonly used ones in the clinical practice are the recognition acuity tests, such as the direction identification test like Landau's C chart, or letter identification test like Snellen's letter chart, or Logmar visual acuity chart. Visual acuity, despite being the most common and most important, a recent meta-analysis by Kessel et al. Suggested that pre-operative visual acuity alone is a poor indicator or a poor predictor of both post-operative vision and patient satisfaction. Hence, it is important that other components of vision, such as color vision, contrast sensitivity, and disabling glare, is also measured and documented. For the measurement of contrast sensitivity, Pelly-Robson chart is frequently used, and contrast sensitivity can be measured for the patient. Now, coming to the external examination, in which we'll have a look at the body habitus, which includes extensive neck fat, kyphosis, ankylosing spondylitis, generalized obesity, and head tremors. We also have to look for any abnormalities of the external eye, and this should be done under diffuse torchlight examination. We have to see whenever we are beginning our ocular examination, we should do it in a step-by-step approach. And we should begin from the external eye in diffuse torchlight examination for the presence of xanthelasma, dermatochalasis, enophthalmos, or a prominent brow. Also check for the motility, free and full motility of the extraocular muscles. And we'll also check for the ocular dominance for if we are planning a monovision for the patient. Now coming to the slit lamp examination. A thorough slit lamp examination is the crux of preoperative evaluation of cataract. We should not straight away go to the cataract. Rather, we should begin from the lid margins, that is from the ocular adnexa, to look for entropion, ectropion, and any eyelid closure abnormalities, misdirected cilia, for the presence of meibomian gland disease. Severe blepharitis or acne rosacea may pose an increased risk of endophthalmitis and should be treated before cataract surgery. Also, Roplast test, that is regurgitation on pressure over the lacrimal sac area, should definitely be done, and active nasolacrimal disease should be ruled out prior to surgery. Rule out any conjunctival congestion or infection. We should also see for the presence of any symplepharon or shortening of cornices, as these may indicate any subtle ocular cicatricial pemphigoid signs, which may get aggravated after we have done the surgery. Further, we rule out the presence of any dry eye disease, which is evaporative or aqueous deficiency. More so, we have to be particular about the cases of thyroid diseases, rheumatoid arthritis, and other autoimmune diseases, which are usually associated with severe dry eye. So it has to be seen that ocular surface has to be optimized very well before the cataract surgery to get correct biometry and to get correct, to avoid any kind of post-operative inflammation of the ocular surface. Then coming to the corneal endothelium, from the epithelium, we have to see for any subtle signs of Fuchs dystrophy also, which may cause corneal decompensation after surgery. So what is extremely important is to evaluate the endothelium very well. Then we have to see the depth of the anterior chamber. In this, the irregular depth may be an indicator of poor zonular health, which is seen in PXS cases, pseudoexfoliation cases, or retinitis pigmentosa cases also, which have got poor zonular health, or traumatic cases. Then you see the iris for any atrophy or spiraling, which might indicate earlier uveitis or attacks of angle closure glaucoma. We have to look at the pupillary margin for any PXF, moth-eaten appearance, and the mid-periphery of the iris for transillumination defects, which may be seen in pigmentary glaucoma, any tremulousness or neovascularization, because all of these factors have a bearing on intraoperative and postoperative cause and subsequent outcomes. Then we see the pupils. We have to see the pupillary reactions. Check for the maximal dilatation of the pupils, especially in diabetes patients. And if those who are having prior attacks of uveitis, they may be having posterior synecdoche, and we have to see how much dilatation is there of the pupil prior to surgery. Now coming finally to the lens. When we come to the lens, we have to see the grade and the type of the cataract. And we also have to see whether there is a posterior polar cataract, which is difficult to identify in the cases of advanced nuclear sclerosis. So for that, we have to be particular, and zonular apparatus examination for the zonular health. Now here we see that this is the LOCS classification, that is the lens opacities classification system 3 for cataract grading and classification, which is widely followed for scientific and research purposes. In this, they have classified nucleus sclerosis according to the basis of color or opalescence from grade 1 to grade 6, and then cortical cataract and posterior subcapsular cataracts from 1 to 5. Do not forget the importance of doing a thorough fundus examination or a retina examination by a 90T indirect slit lamp biomicroscopy and indirect ophthalmoscopy to rule out any developmental abnormalities, any degenerative conditions like AMD, epiretinal membrane, diabetic retinopathy, any prior vein occlusions or retinal artery occlusions, or any other optic nerve pathology, and most importantly, glaucomatous optic nerve cupping. So if you're not able to see the fundus or the retina due to advanced cataract or poor media, then ultrasonography B scan should be done to rule out any gross retinal pathology. Then there are certain special tests which need to be done in certain cases, like potential acuity should be done if the vision loss is not consistent with the cataract, or if vision loss can't be attributed to any of this pathology. So we get a rough estimate of the potential acuity that the patient is likely to achieve after cataract surgery to prognosticate the case. Visual field testing should be done in the presence of optic neuropathy, which may be glaucomatous or neurological if the patient's vision permits to prognosticate the case. Now we come to specular microscopy. We all know that endothelium is the structure of the cornea which maintains the transparency. So specular microscopy should be done in the cases who are having endothelial gutty, patients who are say 75 or more than 80 years of age, and who are suspected of having Fuchs dystrophy. Here we study the cell density, which is the number of cells per millimeter square, the coefficient of variation, which denotes the variation in cell size, hexagonality, or how many cells are exactly hexagonal in shape, and also the central corneal thickness. So as you see here, in early and advanced Fuchs dystrophy, there are large cutty and number of cells also have decreased. So it has been suggested in various publications that if cell density is less than 1,000 cells per millimeter square, or corneal thickness is more than 640 micrometers, there is a very high possibility of corneal decompensation after cataract surgery, despite all precautionary measures. So accordingly, the patient has to be counseled, and accordingly, the type of procedure which would be required for the patient, that should be done. Now here is corneal topography and corneal tomography pictures, which is helpful in the cases of irregular astigmatism, which may be due to Salson's nodular degeneration, epithelial basement membrane disease, or pterygium. It is also helpful in the cases of early keratoconus or previous keratorefractive surgery, also in the cases of pellucid marginal degeneration. Also, corneal tomography is helpful for the measurement of angle kappa if we are planning a multifocal implant for the patient. Though it has not been suggested to do macular OCT in all cases routinely, yet it is being increasingly done nowadays routinely to detect subtle macular pathologies at higher centers. It has been established that between 10 and 17% of cataract patients may have macular findings which are likely to be missed on clinical examination. The most common being epiretinal membrane followed by AMD. Then there are certain objective tests of macular function which may not be having that much clinical significance, but these must be known to the postgraduate students, which include the Maddox rod test, photostress recovery time, blue light entoptoscopy, and ERG and VP may be indicated in certain cases of retinal dystrophies or optic neuropathies. Now we come to the ocular measurements. The important measurements which are currently needed nowadays for biometry are axial length measurements, keratometry, preoperative phakic anterior chamber depth, lens thickness, horizontal white to white in millimeters, and refraction. As Dr. Warrenhill has stated, perfection of one individual component may not significantly affect the outcome in a series of patients. However, if one measurement is incorrect for that individual patient, a refractive miss is guaranteed. So biometry has to be standardized, and we have to ensure that the measurements are taken before any procedures that could alter the tear film or ocular surface, such as it should be done without applying any drops or even before any non-contact biometry. So if we have evaluated the patient on a certain day, then we can call for biometry or these ocular measurements on the next day itself when the patient has a virgin cornea and no procedure has been done on that. Non-contact optical biometry utilizing step-first technology has become the gold standard because of its ease of use, technical suitability, and repeatability among different instruments. Topography and tomography, as I've already stated, are highly recommended in addition to biometry for refractive cataract surgery. Then in the end, there are certain laboratory investigations which must be ordered. Once we have done all the clinical examination and all the calculations are done, we need to write these laboratory investigations. So worldwide, there is no consensus as such as to what laboratory investigations exactly should be ordered. And there is always a controversy regarding the blood sugar levels also. But we know that there are certain investigations and we have to formulate, depending upon what has been said earlier in various publications, a certain plan for as far as laboratory investigations are concerned. So it is important that the patient is optimized systemically with normal blood pressures, normal blood sugars, and normal glycated hemoglobin. And also, the patient should have normal renal function along with normal urine examination. The purpose of all this is to rule out any potential source of infection or any kind of pathology which may be there and may predispose to problems during the surgery itself, because the patient may be requiring hyperosmotics intravenous preoperatively or postoperatively, or sometimes maybe we may need to give oral carbonic anhydrase inhibitors also. So these renal function and all should be measured, should be documented before cataract surgery, and it should be optimized. Also, we should not forget that the patients which we are dealing with are geriatric patients largely, and we need to assure them of justified outcomes and be patient with them at the same time also. An electrocardiogram also very helpful and handy in such patients. We would also need the triple markers just like it is required for any surgery. Now, besides these, if there is a monitored anesthesia care or if a general anesthesia is planned, then additional investigations may be done as added by the anesthetist. Thank you so much.
Can I have some questions for you?
Yeah, sure, sir.
Dr. Indu, first of all, I congratulate you for a very comprehensive presentation on preoperative assessment of cataract surgery, because it is of paramount importance. The younger generation should realize that if you jump and avoid this important aspect of surgery protocol, you may land into trouble and patient may not get desired results. So really, you have done a commendable job. Regarding blood sugar level, you have rightly mentioned that there is a controversy. My take is that if on the day of surgery, if RBS is below 200, I'll take the patient for surgery. I'd like to know your views about that, number one. Number two, many times, not sometimes, but many times we get patients who have cardiac ailment and they are taking some medication, and most of them are on blood thinners. The older protocol is that stop blood thinners 5 or 6 days prior to surgery and then ask the patient to turn up for surgery. But now that we are doing Phaco, which is virtually a bloodless surgery, I mean, a day prior to surgery, the patient may be asked to stop the blood thinner. But what is your take on that? Number two. Number three, a very important point which for the younger generation to realize that please exclude associated electrocystitis disorder. That is of a great importance. Give 10 seconds, press the sec area, look for regurgitation. If it is okay, forget about it. But if there is an associated necrocystitis, first, conquer that, manage that, and then plan for IOL surgery. Because I have seen some patients doing punctum occlusion just to bypass that DCR surgery or any other kind of surgical maneuver, and they are more keen for IOL surgery. So I would like to know from you as to what is your take on RBS, what is your take on blood thinners, and what is your take on associated chronic rectocystitis. And of course, you have rightly mentioned that if the cataract is dense, you should not forget examination of fundus of the fellow eye. That is of paramount importance. Please comment.
Thank you, sir. First of all, I would like to take the first question that you said about the levels of blood sugar, because there is no consensus as such upon to the levels of blood sugar that would be should be we should stick to. So as far as my take goes, I would like to have a normal fasting blood sugar till say 130 and a postprandial of 180, because we have to have be at a certain value. Though 180, if it goes to 190, doesn't I don't think make a difference. But we have to stick to a certain value to establish standards. So
Quite
180
true.
is mine, and 120, 130 is mine for fasting as such.
Okay.
But in such cases who are poorly controlled and who are having long-standing diabetes, I would like to do an HbA1c also, and I would like to it to be somewhere around 6.5 or 7, and not more than that. So because and of course in the absence of any signs of retinopathy. So if these are there, then I can go ahead with my surgery. Any signs of retinopathy with these levels of blood sugar, of course, I would like to optimize even more. So that is my take on blood sugars. And number two, as far as blood thinners and anticoagulants are concerned, because it is a bloodlet surgery, as already you have
Yes.
pointed out. So I don't take anything as such whether this should be stopped or not. Though I get these things, these suggestions from the cardiologists, and that it has to be stopped prior 7 days or something like that. But even then, for my surgery, I don't think, and I have not encountered any complications as such related to this. So again, for anticoagulants and this double platelet therapy, I would not like to stop. Let the patient enjoy his normal cardiac status with the drugs, and I will go ahead with the surgery. And thirdly, chronic dacryocystitis, of course. Any infection, any source of infection has to be controlled. There we have to
Put our
come
thumb.
out of this thing that we have to proceed with the surgery without doing that. So of course, plenty of time should be given to the patient as far as the control of infections is concerned and the optimization of ocular surface is concerned. So that is my take regarding all these three things.
And if
Yeah,
you
sir, can I
find
see
some,
any
sorry,
regarding the blood sugar levels? Any difference of opinions? Dr. Nepali, what is your preferred practice pattern for?
ma'am, if RBS on the day of surgery is below 200 milligram per deciliter, I'll go ahead with IOL surgery on that day.
Dr. Vandana?
Because most of the patients are on dietary control, on oral hypoglycemic drugs, so there is no fear. Associated necrocystitis, I'll first plan DCR surgery. Maybe patient has to wait for 7 to 15 days, but in the interest of the patient and in the interest of the outcome of IO surgery, I would put my thumb if there is an associated DCR. I have seen few of my fellows doing punctum occlusion just to bypass this associated source of infection and do IO surgery. In my opinion, that is unethical. Okay. And blood thinner, one day prior to surgery, I still, keep on asking the patient to
Do you
stop
have
it
the
a
same
day.
opinion for mature cataracts and complicated cataracts, sir?
Uh, it depends. It depends. So I was keen to ask Dr. Indu, was your touch this point. What will you, what do you mean by an inspissated cataract? First, let me know, Dr. Indu.
Sorry, sir. For which cataract?
Inspissated cataract. Have you
You
heard this
mean
term? It's
no,
an
no, I
old
have not.
term. Oh,
Intumescent?
Yes. No, no, no. When we talk about, when we teach the undergraduate and postgraduate students, we say that senile cataract has got so many stages: lamellar separation, incipient stage, mature cataract,
Okay, incipient
intumescent
stage.
cataract. Then hypermature cataract, that is of two types. One, it swells up. The cortical matter gets liquefied and the nucleus sinks at the bottom of the lens. That is Morgagnian cataract. Two, the lens shunks because there is auto absorption of the cortical matter. The small nucleus is there having anterior and posterior capsule attached to it. It's a very small cataract. The chamber becomes deep. That is called as inspissated cataract, and that requires little special attention when you are planning surgery. That was the point.
Dr. Conrad, do
Inspissated
you want to add to the discussion of preoperative biometry assessment? Your experience between the biometry by ultrasound and
When we talk of cataract nowadays, I think we have a very different, two different subsets of population we deal with. One is the rural population where actually you are removing a cataract. And nowadays, when you move towards cities, cataract surgery is becoming more of a refractive surgery now. We are doing cataracts even with 612, where in a rural or a very small town setup, you wouldn't even think of it. Again, in big cities, we are using those high value lenses, toric, multifocals. So it's so refractive that, nowadays, like I said, biometry has to be very accurate. So generally, of course, when you're dealing with that subset of population, again, like I said, your threshold for complication results has to be very low. Of course, and in my setup, I'm in a city like Gurgaon, and most of our population is the elite. So of course, we have the IOL Master 700. But of course, my organization even has centers in small towns like Fatehabad or Sirsa. There Lenstar or these kind of. But of course, yeah, some places even have the ultrasonic biometry. But yes, nowadays more or less most centers try to incorporate, the optical biometer in their preoperative workup. So like Sir said, yeah, any RBS below 200 is should be okay. But like I said, nowadays we are, because of course cataract surgery is the most commonly performed surgery. But so many, like all of us in our practice would know that so many of us are now doing things just to cover up the medical legal aspects, because one end off is enough to give you a headache for an entire year, and the patient's tone changes entirely. If there's a complication like an end off, the any preoperative patient who will be your friend or very thankful will suddenly become against you. So we are doing a lot of things for just for the medical legal workup. So a lot of our places we are even doing the HIV, HBS, AG checking in the certain belts where these diseases are, there are very high positivity rates of that. So yes, there are some tweaks in the preoperative workup from area to area that we all are following. But of course, general fitness, like, an RBS, an ECG, a blood pressure. So generally, yeah, we do take wherever possible, we insist on patient bringing a physician clearance also for surgery. And yes, although like it's been discussed, it's a blood-led surgery, but again, we do ask patients to stop their ecosprin and blood thinners. And in between, in fact, for many years, we had stopped prescribing those preoperative antibiotics. But again, like, in my organization, we have a consensus that no, wherever possible, let's do it, even if it covers our, suppose we land up in a problem later on, we would be sure that, we would show that, yes, you've done the best possible that can be done. So yes, like to answer your question, more or less, the optical biometry is the standard now. And yeah, sir pointed a very nice point about this dacryocystitis, which the younger generation is somehow forgetting that it's a very important aspect. And yeah, and again, one more thing is, what we insist is that on the day of surgery, we do not do any contact examination, do not do an applanation, do not do a contact biometry. So if that has been done, then we again postpone the surgery. So no contact examination to be done for the eye on the day of surgery. This is another important thing that we follow here. Yeah, so that's it.
Ma'am, if you permit, I have another thing to
Sir, if you don't mind,
talk,
I'll just
talk
request
about.
Rajan or Dr. Rajesh if they have any comments.
Sure.
Yeah, I think entire thing have been very well covered by Dr. Indu. But I just have one comment to make. Usually, we don't keep standby anesthetics in our theater. But I make it a point that he has to be there before incision, and he checks all the records of the patient, whatever is there. And of course, blood pressure and sugar are important thing for me as well as for the patient as well, because you never know when it will fluctuate later on. So blood sugar, HIV, HbSHG, ECG, and medical fitness, that is the routine thing we do in our setup. And I think everyone will agree that these are the most important thing as well as medical legal cases are concerned. That is what I want to say, I think. Otherwise, very nicely covered.
Yes, wonderful points, Dr. Rajesh. Dr. Rajan?
Yeah, yeah. That's why that's the Dr. Rajesh has highlighted the salient points of the preoperative examination. One thing I would like to highlight: most of the times the patient is taking antihypertensive medicine, the atenolol tablet, which causes the bradycardia. When we are going to take the patient under the block, so it causes the oculocardiac reflex, which also causes the bradycardia. So it's pretty dangerous to. We have to stop the atenolol drug before giving before the surgery. That's one of the important things, and the importance of the physician checkup. That is the most important. Patient should go undergo ECG and all the three viral markers. These are the most important things to be seen, and the good adequate control of blood sugar, and even the post-operative emphasis of the blood sugar controls, because once the patient has undergone surgery, he always forgets that he or she is a diabetic patient, and they start eating sugar. So the most important things to be emphasized to the patient: adequate strict control of blood sugar for the next 15 days post-operatively to avoid any complication related to the diabetes. Thank you.
Yes, sir. Please go ahead, sir.
One thing I would like to learn from the fellow panelists and the speaker, what should be the cutoff line for taking a patient for IOL surgery? What preoperative visual acuity? I mean, because as per law, anything better than 618 should not be taken for IOL surgery. But scenario has changed with the advancement of technology and everything, that even 6/9 vision and patient is feeling handicapped. Uh, I mean, people plan for IOL surgery. Even people have given a term like invisible cataract to operate such cases. But what should be the, the basic cutoff line if we want to teach our PG students, and if you want to give a standard line of protocol to our younger ophthalmologists?
I think
Any
I would
comment?
like to speak on this.
Yes.
What I am in my institute, we are following is a very standard line, is that if the patient is complaining of having glare or halos, or also telling that I am not able to do my day-to-day tasks regularly, they would like to go ahead with the cataract surgery, then please go ahead for it. Even if there is a cortical cataract or a speck of cataract and the patient is finding it difficult, let's go ahead for the cataract surgery. Secondly, there is a score called DLI score, which is evident in eye trace machine. In that DLI score, often it is seen that some patients who have complained of having difficulty in night driving or night difficulty, there is slight amount of cataract which is just developing. And if the score is towards the red or towards the yellow, we can always tell the patient that yes, you are developing cataract. You have to tell us when you want to get the surgery done. So there is no hard and fast rule for the vision per se, but nowadays it depends eventually on how the patient perceives it. So night drivers and patients who are finding it difficult to drive in the evening are the first people who will come up and ask for cataract surgery early, because they say that it is very important for them, especially when we have drivers who are driving all these, these cars in the evenings. They often come early as compared to normal other people. People who are having desk jobs, they will not find it that difficult. So these are the two things that I would like to say about it, sir.
Thank you.
Very nicely answered, Dr. Aishwarya. In the interest of time, I request that we move ahead to the next presentation.
Okay, I would like to share my screen now. My name is Aishwarya, and today I'll be speaking on my topic, which is phacoemulsification, phaco machines. Can I start my topic?
Yeah, Dr. Aishwarya, I'll just introduce you.
Yes.
So, Dr. Aishwarya is a consultant at Narayan Nethralaya, Bangalore, and she's in the Department of Cataract and Refractive Surgery. She is a surgeon with 12 years of experience in cataract surgeries. She heads the Hospital Infection Control Committee in Narayan Nethralaya as the chairman and has a keen interest in biometry, IOL power calculations, complex cataract surgeries, post-refractive cataract surgeries, Phaco machines, and surgical training of fellows and postgraduates. She has several publications in national and international index journals. She's going to talk today about Phaco machines and Phacoemulsification. Over to you, Dr. Aishwarya.
Thank you, ma'am. So today my topic is a very humbling topic because it deals with phaco machines and phacoemulsification, basically our bread and butter. And today I would like to talk about a few, the two aspects in two separate sections. One is the phacoemulsification and the other one is phaco machines. In phacoemulsification, we'll start with the introduction and history where I think all of us owe our livelihoods to this particular person who started who's known as the father of phacoemulsification, Dr. Charles. And Dr. Charles actually did the first phaco procedure in 1967, and he coined the term phacoemulsification. This was taken up by the word phakos in Greek, which means lens. And after that, I think we had a spade of brilliant minds who got a lot of things into the system as we all know it right now, from its inception to now, where we are using very sophisticated machines in India and all over the world. And a lot that we have taken for granted today and has happened after a lot of hard work of many unknown individuals for us. Now I would like to go ahead and talk about the principles and techniques. We know that the ultrasound energy is used to emulsify the nucleus, and the fluidics are there to counteract the potential heat buildup, and eventually this leads to phacoemulsification. This was with evolution, we have realized that it is not just as that simple. We have to talk about the energy in just a minute. So we have to talk about the energy, the fluidics, the lens fragmentation, the thermal management, the aspiration, surgeon control and automation, and safety mechanisms as well. Now, coming to the initial part, first of all, we would like to talk about the Phaco probe as such. The Phaco probe, this is a Phaco prototype probe where you have a power cord, the aspiration line, and the irrigation line with ceramic elements and connecting body with Phaco's tip and sleeve. The core mechanism of ultrasonic energy is all about that the phacoemulsification handpiece generates ultrasonic energy through vibrations of titanium tip or metal tip. The frequency of this ultrasound ranges from between 20 kilohertz to 60 kilohertz, ensuring rapid oscillations. The type of energy delivery happens with longitudinal method or the torsional method or the transverse method or the different kind of oscillations which give a more consistent energy delivery. With this, let's come to the initial part, that is the phacotip and needle and piezoelectric crystals. The ultrasonic energy is generated in piezoelectric crystals shown here in red, and it is conveyed by the horn purple, which is whose funnel shape amplifies the amplitude to the metallic tip at the end. This is used to fragment solid pieces of lens matter, allowing their aspiration. The phaco needle tips can have various configurations. For example, the 0 bevel, the 15 bevel, the 30-degree bevel, or the 45-degree bevel. They can have straight tips or angled or Kelman tips, depending on the preference of the surgeon. Um, Talking about that jackhammer effect, which is very important in phacoemulsification, it is a mechanical action where the phaco tip rapidly moves backwards and forwards, striking the cataractous lens material repeatedly, which is similar to how a jackhammer breaks up concrete. This is considered to be the primary mechanism responsible for lens disruption during phacoenergy with minimal contribution from cavitation forces. The cavitation forces are also very important because it means that the formation of gas bubbles have formed in the anterior chamber secondary to the pressure changes at the phaco tip. Tiny air bubbles are created during the backward stroke of tip movement due to the sudden reduction in pressure. They initially grow over several stroke cycles before imploding, creating a pressure wave. So the compression cycle creates this cavitation, helping in the phacoemulsification part of it. Next topic, which I would like to talk about, is chattering. What is chattering? Is basically when the lens fragment bounce off the phaco tip during cataract surgery. Now, this chatter is caused by lens fragments. The ultrasound energy, that is, the increased ultrasound energy, can increase the inertia of the lens fragments. Harder nuclei, where the more harder the nuclei, the more chatter it is. So how to reduce the chatter? You can decrease the phaco power, use a variable rise time. You can use phaco pulse and phaco burst modes and lower the flow rate. With this, the benefits of chatter are that you reduce the endothelial trauma, make the phaco more efficient, reduce the amount of vacuum needed, reduce the bottle height, reduce the dynamic rise time, and simplify the number of procedural steps. Duty cycle. What is duty cycle? This is basically nothing but the ratio of power on time to the total time. This duty cycle, if it is lower, then it means that the decrease in the total energy delivered to the eye, which can be beneficial for minimizing tissue damage and heat generation. If it is higher, then it delivers more energy per pulse, potentially allowing for faster cataract fragmentation, but with increased risk of thermal damage. Coming to the next topic, which is basically frequency, stroke length, and power. Frequency is the speed of movement of the phaco needle to and fro. The phaco frequency can be more than 20,000 hertz, and it is between something around 27,000 to 60 kilohertz as well. The stroke length is the distance traveled by the phaco tip to cavitate the lens material, and the normal stroke length is between 0.05 to 0.10 millimeter. And power is the ability of the phaco needle to vibrate and break down the lenticular material. The power is dependent on stroke length, and it is the linear percentage of stroke length of the phaco needle. Power is produced in the phaco in the position 3 of the foot pedal. With this, let's move on to the fluidics of the phaco. The primary rule of fluidics is to basically keep the inflow greater than the outflow. Here we'll talk about the irrigation aspiration, the pump systems, and the dynamic fluid management. Let's talk about the different topics over here, which is the aspiration flow rate, which is the measure of fluid moving into aspiration port and tubing in cc per minute. It is proportional to the rotational speed of pump head in the peristaltic pump, and it is preset by the surgeon. Vacuum, I'll talk about it in details in the next slides. This is difference between the atmospheric pressure and the pressure in aspiration tubing. It causes negative suction pressure, and vacuum rises only on the occlusion of aspiration port and peristaltic pump. Compliance. Compliance is the stretchability or rigidity of the aspiration tubing, which determines the vacuum rise and the surge. Irrigation tubing or the inflow has larger diameter, has higher flow, thinner walls, high compliance, and is softer. And aspiration tubing outflow has smaller diameter, lower flow, thicker walls, lower compliance, and is harder. Now, resistance to flow basically depends on the diameter of the tip, the bevel angle, viscosity of the fluid being aspirated, and it determines the resting or the pre-vacuum vacuum rise time and the surge phenomenon. We have the vacuum rise time, and it is a time to reach the preset vacuum, which depends on the AFR, the lumen length and compliance of the aspiration tubing, and the outflow resistance. Rise time is proportional to the AFR and is proportional to the pump speed eventually. Now, coming to the surge. What is surge? Surge is basically nothing but the sudden sensation of occlusion when the occlusion is built up and then the high vacuum happens. Then the occlusion gets broken down, fluid gushes into the phaco tip. It exceeds the inflow capacity of the irrigation line, hence there is shallow AC. You can prevent the surge by decreasing the preset vacuum, decreasing the flow rate, stiff and short tubing, tighter wounds, and raising the bottle height, Or you can use something like aspiration bypass system, which is around 0.18 millimeter in size, a hole present in some of the phaco tips. It allows for higher vacuum levels to be achieved safely. It helps prevent the post-occlusion surge and anterior chamber collapse. It also cools the tip to prevent corneal burns. So basically, whenever over here the occlusion happens, the tip gets occluded, the flow is directed to this ABS port and the irrigation flow occurs. You can also have something which is known as cruise control by SART surgicals. Cruise control is nothing but a device which was present just behind the phaco probe over here. In this, the cylindrical wire mesh traps the nuclear emulsate but allows the fluid to pass through. So these are the mechanisms by which you can actually decrease the surge. Last but not the least, the venting. Venting is nothing but occlusion of phaco tip by nuclear fragment where the vacuum is created. And when the vacuum reaches to the maximum preset level, the vent valve will open and some air or fluid will enter into the system depending on the type of the vent. This will help to prevent the exceeding vacuum from preset level, and no more vacuum will be there beyond the preset level. This vacuum venting, this venting can be done by air venting or by fluid venting. Air venting can expand more during occlusion. It increases compliance of tubing and is less effective in preventing surge. And thereafter, fluid venting expands less during occlusion, compliance is less, and it is effective in preventing surge. Coming to the different pumps, we all will be talking about peristaltic pump and eventually pump eventually, but we also need to know about the vacuum pumps, the rotatory pumps and diaphragmatic pumps. The vacuum pumps regulate the vacuum pressure directly along the length of the tubing and the flow rate of the liquid indirectly. In rotatory pumps, the vacuum created is directly related to the speed of the rotation of the pump. And then diaphragmatic pumps is basically to extract air or another gas contained in a chamber in order to reduce the pressure in the chamber, thus creating a depression that aspirates the liquid into these chambers. A peristaltic one-prime venturi pump are basically the peristaltic pump is the basic function is all about flow control, and it causes vacuum by occlusion, and there is low flow and high vacuum is possible over here. It can be used for delicate work. It gives little rests which are difficult to grasp. It has helps in low traction and releases particles which cause loss of occlusion. In venturi pump, this is a vacuum-based pump. It helps in giving you quickly available vacuum without occlusion. There is no flow control, and low flow and high vacuum are not possible in this venturi pump. It can be efficient for fast core removal, for traction, and for during turbulence. Now, coming to the lens fragmentation part, lens fragmentation, we will talk about emulsification and energy efficiency. Now, in emulsification, we have the traditional longitudinal ultrasound energy and the torsional ultrasound energy, which was introduced in Alcon's Ozil torsional phacoemulsification. Instead of back and forth movement, the tip oscillates in a side-to-side motion in a torsional ultrasound energy. Here, we have less energy dispersion and reduced corneal endothelial stress. And whereas in transversal and elliptical ultrasound, there is a combination of longitudinal and torsional movement which occurs, and it provides a smoother fragmentation process and reduces ultrasound heat. We have different modes as well, the pulse mode, the burst mode, and the hyperpulse mode. They basically deliver, the pulse mode delivers ultrasound and controlled bursts instead of continuous energy. The burst mode has short intense bursts of energy followed by a rest period. And in hyperpulse mode, it delivers extremely short pulses at different high frequencies. Energy efficiency, we have to remember about the different tips. We have just spoken about those tips, the cavitation effect, and the fluidics and flow dynamics. The aspiration rate, if we remember, if it is too high, it can lead to tip occlusion and sudden bursts of energy or cause surge. There can be infusion rate, where proper regulation helps in stabilizing the anterior chamber and reduces unnecessary turbulence. And occlusion mode, where modern systems detect occlusion and modulate energy for optimal efficiency. Occlusion mode phaco is more energy and time efficient than sculpting mode. Coming to the next portion where we are talking about the thermal management. Here, the White Star signature technology, the Infinity Vision system, and Stellaris all have different systems due to which the heat generation can be less, and there can be cooling mechanisms which are like a constant irrigation flow and coatings on the phaco tip, which can help manage heat and protect surrounding structures. Coming to the aspiration, we have fragment removal and vacuum settings. Let's talk a little bit about vacuum. What is vacuum? It is the negative pressure that holds the nuclear fragments in the phaco tip during cataract surgery, and the vacuum level is measured in millimeters of mercury. You can have it as a holding power, which will determine how well the nucleus material is held to the phaco tip. It can help you for fluid flow and for the dynamic levels. Remember that the vacuum levels changes throughout the surgery. For example, lower vacuum levels are used during nucleus sculpting, while higher vacuum levels are used for chopping and fragment removal. Having said that, let's talk a little bit about the pumps over here. The vacuum is first of all controlled by foot pedal and peristaltic pumps, which help allow the surgeon to set vacuum, which limits independently of flow. And in peristaltic pump, as we know, it is flow based, and the vacuum is created in occlusion of the phaco tip. The flow is constant until occlusion, and it drains into a soft pad, and it has less followability as such. The vacuum is important for the efficiency of the phacoemulsification process. It helps to maintain the anterior chamber. And highest vacuum is obtained after complete occlusion of aspiration port, and the speed with which this level is reached is determined by pump flow settings. As well as when you come to the Venturi flow, the Venturi pump, it is a vacuum-based pump where the vacuum is created instantly via the pump, and the flow varies with vacuum level, and it drains into a rigid cassette and has more followability. Coming to the surgeon control and automation, we'll talk about the foot pedal control. The Phaco foot pedal is the primary instrument used to control the phaco machine during cataract surgery. You can have 4 positions, basically the position 0, which is resting and fully upright point of foot pedal. Position 1, where you have only irrigation. Position 2, you have irrigation with aspiration. Position 3, where you have irrigation, aspiration, and power. This is something which is very, very important to understand, that the excursion of foot pedal millimeter to produce unit power of phaco energy. The foot gradient from position 0 to 3 is 10 centimeters or 100 millimeter, and maximum preset phaco energy is 100 millimeter, is 100%. Then you will have 1 millimeter of excursion with 1 unit of power. If the phaco energy is at 50%, that means you will have 1 unit power per 2 millimeter of excursion. And if the phaco energy is at 25%, then you will have 1 unit power per 4 millimeter of excursion. Phaco maximum is therefore set at the minimum power that is required for that particular step. These are the complications that we can encounter in phacoemulsification process. I would not like to go into the details of it given the time constraints, but here I would just like to talk about CSZ, which is basically the area which is bounded vertically by the cornea on the top and the posterior capsule in opposite direction. It is the area with the maximum space in the AC. All the aspiration should be done over here where it has the maximum safety. Remember, the increased CCZ will happen with myopes, zonular cell syndromes, and vitrectomy eyes, and decreased area will be present in hypermetropes, small eyes, and small CCC. And the capsular fornices and the angle region are thus the areas where it is dangerous to do phaco aspiration, and this constitutes the peripheral unsafe zone. Now, let me talk about the phaco machines. Today, I've decided to divide this topic according to the different machines that we have with the different companies. I'll go one by one. So this is the overview. This was one of the flyers which I had made for a particular website. And then you can just have a look at the overview of phaco machines. And over here, you have the left-hand side, you have basically Venturi with peristaltic machines, and the right-hand side, you have peristaltic machines most of the time. We'll go one by one. So let's come to Alcon. Alcon started with first Phaco emulsification machine 1967 by Dr. Charles Feldman. And now in 2024, they are about to launch 2025 onwards that Unity. So let's just see their journey. So this first Cavitron machine was the first phaco emulsification machine by Cavitron Corporation, and eventually was taken over by Alcon. It had peristaltic pump and magneto-restrictive ultrasound handpiece. It had fixed ultrasound power settings and irrigation aspiration techniques, which was IMAX and IMN for cortical matter mode only. The problems were many. The problems depended on that the handpieces required cooling, the operators required to monitor a flow meter to ensure that the vacuum did not exceed irrigation levels, and the handpiece required manual tuning. There were no viscoelastics at that point of time, and the setup was critical to maintaining sterility. Coming to the next machine, this machine had a first phaco device with a piezoelectric ultrasound handpiece. It had a lighter handpiece and mode selection knob with the options with ultrasound IM in and IM max. Since it went to the piezoelectric crystals, this was basically lighter in weight, easy to sterilize, and the external cooling was not required, and a homogeneous ultrasound was given over here. Coming to the next machine, Centurion 2013, the USP of this machine is active century and active fluidics, and also the non-traditional peristaltic pulp. Let's talk about the working parts of this machine. We'll just have a look at the machine, how it looks like. What is important to see over here is these active fluidics bag bay, where the active fluidics, the BSS bag can go inside, and then the fluidics can be taken control of. This also has been using the interplate balance tip. This has enhanced the characteristics of the ozil torsional motion. The maximum lateral stroke available is around 180 microns. It enhances the energy distribution and improves the efficiency of phacoemulsification. The balance tip with double bend is something that I also personally prefer for my phacoemulsification needs. Foot pedal over here in Centurion is a wonderful tool which is highly customizable. It can be connected with cable or wirelessly. And wireless foot switch hangs at the back of the machine. If it is used in wireless mode, it charges by induction. And if it is used with wired mode, charges via cable. And just look at this particular table. Over here, you have different modes. Earlier, we have just discussed about the irrigation, aspiration, and phaco modes. But here you can see that different combinations can be present with the help of different positions. And depending on the mode of operation and the type of irrigation selected, the functions can be controlled. And as the foot pedal is depressed, it travels from the resting position into its active positions. This is the screen that you have, and here I would like to talk specially about this particular screen, which is the IP mode. So what is the IP mode? This is the ozil mode. Over here, the ozil initially had a problem where the fragment would clog the tip and plug, particularly with the flare tips. To remedy this, there is intelligent phaco, or the IP mode was introduced to the Infinity, and it is now available with Centurion. This machine gave a short pulse of longitudinal energy to push away the remaining nuclear fragment and then returns to the emulsifying at a preset vacuum. These are the three main cornerstones, which is the active fluidics, the Centurion FMS or the dual segment technology, and the active fluidics, the pump over here. So what active fluidics does is that the bag of BSS is compressed between the two plates. And this the dual segment pump with elastomeric FMS interface comes into being. It has a very small bore aspiration tubing, which minimizes the post-occlusion surge over here. And how does it work? Basically, while constantly measuring the pressure in the irrigation line, aspiration line, and the flow rate at 100 times per second, you have motor control plates over here which squeeze and release the bag, causes the flow over here. And with active fluidics technology, the surgeon selects a target IOP, the patient eye level, and the irrigation factor. And throughout the procedure, the system is maintained to respond to the changes in the vacuum pressure, irrigation pressure, and pump speed. Here, the IOP is maintained, and the target IOP is maintained under the flow and no flow conditions. You have excellent chamber stability and more consistent range of desirable IOP, more natural IOPs targeting optimal followability, enhanced pump efficiency, and reduce occlusion, break, and surge. So interpret balanced, we've just talked about it, and infusion sleeves are also important, where you have you have the maximal torsional tip movement at the distal end while minimizing the tip movement in the incision by way of a unique double bend design. Coming to the active century handpiece, this is just a flow which shows that active century handpiece signals the Centurion hardware, goes to the pressure sensor, goes to the compression plates to adjust the pressure in the BSS, compensating the changes in the eye, and releases the fluid. This is a small table which shows the different Centurions in comparison. And this is Legion, which was released in 2022. It is a very good small portable machine. It has good followability and lower repulsion during procedures compared to earlier systems. Coming to Bosch and Lomb, I'll be talking about Steralis Elite. Steralis Elite is for both anterior posterior segment surgeries. It has attuned energy and adaptive fluidics with dynamic infusion compensation. Here, the attuned energy is all about the handpiece. The handpiece has a 28.5 kilohertz 6 crystal continuous pulsed mode with fixed pulse and multi-burst waveform ultrasound setting options. It has a very good stroke length of 130 microns and has both direct and linear vacuum control. With the foot pedal, the foot pedal has these two abilities, of course, that it can go for both pitching of up and down, but at the same time, the yaw movements is basically helping to put the irrigation on and off, which can be activated with the yaw pane. And there is total independence between the vacuum and ultrasound during all phases of energy. With this, you also have the waveform modulation pattern, which helps the lens fragments to slowly spin on the tip, making them easier to emulsify. Coming to the Johnson & Johnson White Star Signature Pro, this has both peristaltic pump and the Venturi pump, and switch on the fly flexibility, which helps you to do the changes where the peristaltic pump can be optimal for sculpt, crack, and segment control, while the Venturi is well suited for irrigation aspiration. You can have both the kinds of foot pedals over here, the advanced control foot pedal or the advanced linear foot pedal, where according to the surgeon preferences, the foot pedal can be used. They also use Ellipse FX handpiece, which has a continuous elliptical pattern for smooth and efficient cutting and has less corneal edema and lower endothelial cell loss. Coming to Johnson & Johnson Veritas, this has a unique hybrid fluidics technology and a dual pump system with advanced tubing system as well. They also have elevated fluidic management system with CASE technology, that is the chamber stabilization intelligence, automatically regulates the vacuum to reduce post-occlusion surge. And they also have the White Star micropulse technology, which enables the ultra-efficient lens extraction with less energy. And this is the Veritas swivel handpiece, where the swivel designed with 220-degree rotation at distal end, while proximal end remains stationary. We also have Medisonics with Chakshu CX3 machine, which is a very, very well liked machine by a lot of doctors. And it has a peristaltic pump with a very good handpiece, which is having 4 crystal titanium handpiece. And it has a multifunctional HAS technology foot pedal. Coming to the earthly machines, the latest machine is OS4. The OS4 has capabilities of doing all cataract, retina, and glaucoma surgeries, and it also has a easy Phaco technology with power LED technology. It also depends on speed pump, and this speed pump has the same principle as a peristaltic pump, which controls the flow with speed. The vacuum can be controlled using the foot pedal. It enables a precise control of foldability generated right at the tip of opening. It has a high frequency capsulotomy design and a zero Phaco pip, and with IA tip with safety design. Coming to the Zeiss machines has the USP of the Quattro pump, and the type of infusion Quattro is controlled with forced infusion IOP range of 30 to 120 millimeter of mercury. This has advanced power modulation as well. And the Quattro pump has different chambers, that is 2 infusion chambers which control the infusion rate, 2 aspiration chambers which control the aspiration rate, 4 syringe-like chambers which provide synchronized and reciprocal change of fluid, and incisional leakage which gets automatically compensated for. The Quattro pump has a fluidics panel which has 4 inductive sensors, 4 pneumatic ports, and 1 irrigation pressure sensor for measuring the irrigation pressure. This also has something known as power on demand, which helps in followability, and it activates the ultrasound only upon occlusion. And it further reduces repulsion of fragments and has 50% less ultrasound effect because of automated ultrasound, which reduces the Phaco power to its minimum necessity, resulting in 50% less effective Phaco time, and with a relaxed surgical experience. Last but not the least, I'll be talking about Goider, which has this particular machine, which is known as Megatron S4 High Performance System, HPS. It has an age detect technology which detects the via detection of ultrasound handpiece. It has very good efficiency for both anterior and posterior segment surgeries. It has intelligent fluid management system, and it is very profitable in terms of the fact that it is one cassette for all the processes, and there is no intraoperative change which is required. Flexibility is also very good because you can have different languages in which the surgeon can communicate with the machine. And this has a peristaltic pump with something which is having a rise time with the Venturi effect, and it is adjustable to up to 5 seconds. And it also has a direct control pump, which is vacuum based, and with the rise time again of 0.5 to 5 seconds, and ultrasound frequency with 27 to 55 kilohertz. With all this is just a small table where I would like to compare all the machines in total. I think this is beyond the scope of my talk today. I would just like to tell something about the EPT. Here, EPT is basically, we know that it is used in Stellaris Elite Phaco system, where you have the Phaco output level, including the duty cycle, into the Phaco output time. And there is something known as CD, which we know is given as a metric which is given in Alcon machine Centurion, where you have the torsional time into the torsional power into the torsional factor, plus the longitudinal time into the longitudinal power. Both these terms are not interchangeable, number one. The formula are different and they seemingly represent the same thing, but they are not. They should not be compared. EPT measures the power and CD measures the stroke, and both are measures of a good corneal outcome, but this is believed by many, but it is not true. Less CD or less EPT does not always mean that the cornea is going to be crystal clear the next day. And for surgeons, personal levels of these values decreasing with experience can help them achieve better outcomes. And I would like to end my presentation with acknowledgements to my institute, my teachers and my mentors, to all my students, to all the doctors who have contributed to the Phacoemulsification present currently, and the product manuals, and last but not the least, my patients for their continued trust in the process. Thank you.
What an exhaustive presentation, Dr. Aishwarya, and I think you've strived to achieve the impossible and have covered right from Kelman to active fluidics. So I invite comments from Dr. Nepalia.
Ma'am, first of all, compliments to you, Dr. Aishwarya, for a very perfect presentation
Thank you, sir.
on this subject. You have highlighted various machines with their plus points in depth. So I like to know from you that which particular machine you will recommend for a beginner. That is of paramount importance for the beginner, because he tries to see ifs and buts and do, I mean, what planning he has to make for purchasing a new machine in the beginning of his practice, number one. Number two, would you like to comment about followability? Because that is another important point. Are you getting my voice?
Yes, sir. So, sir, there are two aspects to this. One is for the first question.
First is the which machine you will recommend for a beginner. Two, some tips about followability during the phacoemulsification process for the PG students. And third, nowadays there are recommendations of having a anterior segment OCT running along with phaco surgery. So, what is your take on that?
So, for the first question, I would like to say that the beginner should first of all start with the machine that he or she was trained on. Most of the people, for example, we train our students over here on Centurion, but Centurion, as we know, is a very expensive machine. So Chakshu is something that I have not worked with Chakshu myself a lot. I've just had a small demo of that. But this is one machine which I have been told that regularly practitioners are using. It is user friendly, it is pocket friendly, and patient's outcome is very good with Chakshu. At the same time, a lot depends on the financial aspect also, as we all know that these machines are very expensive, and the surgeon needs to decide, the beginner needs to decide when and how to utilize this. Legion is also a very, very good machine, which I would say is something which has given very good results to us as well. So either of the machines, whichever they are comfortable with and which fits their zone. And at the end of the day, you are as good as your technique. The machine at the end of the day should be secondary. So if you are good with one particular machine and you are able to afford and also give good results, I think it is a way forward.
How about Otterly? Because it's a
Earthly is a
very
very, very good
small.
machine, sir. It is
Yes,
a very
I
small, it
mean,
is a very good
you can
machine. It
carry
is
it.
capable
Yes.
of getting carried by the surgeons. It is also a very, very good machine, sir. I totally agree. I've used it. Yeah.
Would you like to now comment about followability?
The followability of a particular during a surgery, I would like to recommend this to the all the PGs and fellows is that whenever you are looking at a particular piece which needs to follow and which needs to be held, please remember that you to have a good occlusion, and also remember to be in the central safe zone. I think these are the first paramount important things that students should remember. And at the same time, remember that Phaco pedal needs to, that the Phaco is all about four limbs, your both hands and your both feet. All these four limbs have to be in sync. And as long as if you worked on simulators first before you go towards any particular surgery for Phaco, it would be always better to go with a simulation first. Nowadays, we have very good simulations and simulators available throughout the country. It would rather be go get a simulated understanding first and then go for a real surgery. Is something that I would like to suggest to people. Unlike what we have learned by trial and by error method, the followability of pieces will be occurring very nicely if they are working on a simulator. That's something that I would like to suggest.
And how do you manage surge?
So for me, I have had the opportunity of working initially with Infinity. And I remember the day when the Centurion had come, and I had done 4 cases on Centurion. That day, I remember that day I actually understood what surge was, because Centurion gave me such a good anterior chamber stability during that time. And that is something which I have actually utilized all throughout. I do not have very high vacuum settings. My vacuum settings on Centurion is only around 550, and I utilize it practically for all my cataracts until unless it is a very hard cataract. And my vacuum settings, other than that, my flow settings are very less. I don't keep more than 60 millimeters of bottle height also. So my vacuum settings and my bottle height settings are quite less on Infinity. And my aspiration flow rate is around 40. So this is the settings that I actually use for all my cases.
Dr.
And how
Vandana,
about
do you want to add to that?
And thankfully, since I use Centurion, I also have the benefit of using the ABS system. So ABS system is something which I'm using regularly for my cases.
how about simultaneous running of anterior segment OCT with Phaco?
Sir, I have utilized this technology as well, and
Right.
it helps you to understand how things are going. But the thing is that once you need to first of all get adapted to it, because in your screen, what you're seeing and what is happening inside over there, sometimes it can be very distracting for the beginning surgeons. But once you get used to it, it's very, very nice, because you know where you are going, where is your probe going. All those things are very good. And if you get used to the system, there's nothing like that. It's very, very gratifying, I would say.
Because Dr. Titial,
Yes.
our Vice President of AOS,
Yes.
he's, doing it.
Yes,
He has
I had this
wonderful
opportunity
results.
of utilizing it for one of the studies that we were doing, and we were putting, you were seeing how much space is available between the IOL and the posterior capsule. So this was one of the studies. Then we understood, how much the bag gets filled up when you release the fluid, when you close down the chamber, or when you have a PCR for that matter. What all turbulences happen over there. It's very, very. Whatever we have read in theory, until unless you see it with ASOCT happening, it's very, very gratifying.
Last query. Some machines have got options of both Venturi and peristaltic pump. Advantage or any, other way around?
Sir, with these machines, it is important to understand how you are accustomed to the foot pedal positions. Both of these machines with Venturi and peristaltic, they have their own disadvantages and advantages, but at the same time, Peristaltic is something for fine things. It is always better to go for peristaltic. If I would say in one word, for example, fine things. For example, if you want to look at just one piece, take it up, make sure that the flow is maintained, the surge is not much, you would go for peristaltic. But venturi is something that you would like to go for methods. For example, if you are going towards the sculpting part or the harder part, you would like to go for venturi. Both the machines, they have both the pumps are very well and good. And the hybrid pumps nowadays, you don't even have to think about it. For example, in Quatera, you really don't have to think with a quattro pump, whether it is venturi or whether it is peristaltic. All you have to do is just the anterior chamber is so solidly maintained
That is true.
in things like in phaco systems like Quatera, you really don't have to bother. No matter how hard the cataract or how less the space is available, you will have a very good, nice anterior chamber happening over there.
So we all agree that a stable entry chamber
Yes,
is mandatory for
it's
any
mandatory.
phaco
It's
surgery,
mandatory.
isn't it? Thank you.
Yes. I am not a very good fan of, not a big fan of continuous irrigation, sir. I feel that it causes a lot of endothelial damage. This is
Okay.
something which I always tell the beginner surgeons, please don't go for continuous irrigation. Try to wean off from it. Initially, it is okay, but try to wean off from it once you're doing numbers.
Dr. Vandana, would you like to add to the discussion, please?
Well, actually, I have to congratulate Dr. Aishwarya. I myself, I was so hooked to her presentation because there are a lot of things I myself learned today.
It
So
was a
we
very
all know,
humbling experience for me too,
yeah,
ma'am.
yeah. So in fact, I think, for students, firstly, you got to remember that you shouldn't get bogged down with so many things. From your exam point of view, from your knowledge point of view, you have to know about the basics. Every Phaco machine will work on these three basics.
Absolutely.
There's the Phaco, there's irrigation, there's the aspiration, there's a balance of all this. And the newer machines are moving towards how to make this safer and safer,
Yes,
like
ma'am.
maintain the anterior chamber, use less of Phaco, which is less damaging to the corneal endothelium, like where you have the pulse mode, the burst mode.
Yes,
And
ma'am.
then, initially we all started with the peristaltic machines
Yes,
because they were safer machines, the movement was slow, you had more reaction time. Then obviously once you become an expert, you become used to the Phaco, you can move on to the Venturi.
yes,
So I
ma'am.
like, so still it's the basics which you have to remember.
Yes,
And of course, like you said, it's the interplay of your right hand, left hand, your foot switch. Also, you also have to remember your foot switch has got it's got all the incorporations of, you should know where is the reflux. Suppose you
yes,
catch the capsule. So it's all about, like you said, any machine, get used to it and not get, overwhelmed. Because again, in the end, it's about you might have the best of the machines, but you have to keep in that safe zone, where
yes,
you protect your capsule, you protect your corneal endothelium, because no case will go by the book.
yes,
So yeah, so it's all about, I think, just have a cool mind and
yes,
remember that you don't have to know everything about the machine. A lot of the mechanisms that you explain are actually inbuilt. A lot of students are like, oh, I don't know when this happens. I don't know when that happens. I will not know when to use the burst mode. I will not know when to use the pulse mode. So it's like most of these machines are like quite user friendly. It's just that, but you have to get used to the machine and to know how to use it when.
yes, ma'am.
So that's the main thing. Even our fellows, we tell them that just remember your basics, and then the machine. In fact, luckily, there are a lot of automatic things in the machine. Just know, and that when you are in a trouble, what is the main thing you have to use to get out of the trouble. Otherwise, as long as the going is smooth, you know, there's nothing to worry about. It's only when you land up in a problem, then you have to know what part of the machine and how you have to use it.
Dr. Rajan, would you want to give any comments to students who are still just beginning Phaco and are learning their basics? So, lovely points, Dr. Aishwarya, and amazing discussion as well. And like Dr. Vandana also emphasized, the beginner need not get bogged down by so many, the variety that is available right now. Get your basics right. And with this, I think we'll move to the last presentation of the day. So I'd like to introduce Dr. Avdish Oli. He is a senior advisor and VR surgeon at Command Hospital, Air Force, Bangalore. He's a postgraduate and graduate student from AFMC L2 batch. He stood second in the batch with 4 distinctions, 1 trophy, 2 gold medals, and 2 silver medals. He stood first in MS in college with a silver medal in MUHS in 2012. He's a fellow of All India Collegium of Ophthalmology in 2014. Stood first in fellowship entrance exit exam amongst all national and international fellows at LV Prasad Eye Institute in 2019. Currently, he is posted as professor and VR surgeon at CHAF Bangalore. Professionally, he modified and innovated the technique for intraocular lens fixation by autologous blood and double flange, which was presented at the innovation session named as Oli's technique innovated a need for named as Oli's technique. He innovated a needle for cost-effective suprachoroidal injection of steroids. He has managed complex cases of VR diseases by laser therapy and minimal invasive instruments with excellent outcomes. From the research point of view, he has 2 ICMR research projects, has presented in national conferences, presented papers of various international and national conferences, and has conducted surgical skill transfer courses in national conferences. He has 56 international, 56 publications, 22 are international and 13 are national, with 3 book publications, and he's a reviewer of various national and international journals, including IOVS and European Journal of Ophthalmology. His special interest is in nature and wildlife photography and trekking. Today he is going to talk about secondary IOLs, glued, flanged, and scleral fixated. With this introduction, I request Dr. Avdish to take over.
Am I audible and can you see my slides, please, ma'am?
Yes, very much.
Yeah, good evening, everyone. Good evening, seniors and AIOS, for this wonderful opportunity to speak here. I'll be talking about the secondary IOLs for management of aphakia. So, diagnosis of aphakia is straightforward. This lecture I have kept as this thing for mainly for the post graduate students. Just a second. So the most common causes, if you see, cataract surgery I'll place first, wherein because of various complications like lens drop, IOL drop, or any posterior capsular rent which occurs, and also cases of trauma. And in a very rare situation, even there could be congenital absence of the lens. The slides are. Yeah, so this is a table which I have picked up from Parsons, and from postgraduate point of view, this is one of the very common questions, that how do you manage aphakia. So what we need to remember, that spectacles and contact lenses are indicated only in certain specific situations because of high magnification given by spectacles and various phenomena of visual distortion because of the edge effect, which are commonly a jack in the box or roving ring scotoma. So in almost all situations of aphakia, we prefer intraocular lenses because their magnification is minimal. So this is just a brief overview. When we have a patient with aphakia with good capsular support, we go ahead with 3-piece sulcus intraocular lens, and if the capsular support is absent, then we go ahead with various lenses which could be placed in various anatomical positions like a ACIOL, iris claw lens, or scleral fixated lenses which could be sutured or which could be non-sutured ones like a glued IOL, flanged IOL, or various other evolving techniques. And risk of endothelial damage is least with the SFIOLs and highest with ACIOLs, so they are not in common use nowadays. And also the SFIOLs, the long-term stability is good. So the previous two lectures, one on the good preoperative workup and knowing your machine, are very, very important to avoid aphakia by trainee surgeon when they start doing their surgery. So it is very important to talk to the patient and to go through their medical records, to do a careful ophthalmological examination so that you can plan your surgery. And it is always good for a beginner to start with doing a mental surgery in his mind before the actual surgery is done, and listening to the mentor during the OR whenever you are doing a surgery, because ophthalmic surgery for a trainee is very, very dynamic. You are as good as a surgeon as your last case. If you create some unusual complication, then your mentor also sometimes may have reservations. And each and every step is important, right from draping to putting the speculum to and ending with putting the intraocular lens, because each and every step is interlinked. And one of the very important steps in ophthalmic surgery to master in the beginning years is your continuous capsulorhexis, and it will be your gateway to all kind of intraocular surgeries. So posterior capsular rent is the most important cause which leads to aphakia. So early recognition is very, very important during the surgery. You know your microscope, use various types of illuminations which you have, like a retroglow is very, very helpful. Then if you find that your Phaco machine is not behaving as anticipated, the followability, as the discussion was going on, sometimes that is a very, very important clue that if you are expecting that the piece should follow, but it has stopped following, so there could be vitreous which is not visible to you. And freezing your movements whenever you see some unusual occurrence has occurred, that is one of the important motor and also a psychological skill to develop during your training, because then your movements, your sudden movements will not cause further damage. And then you assess what is the situation, and if you have this posterior capsular rent, don't try to fish out the nuclear fragments. You will feel that the fragment is just near to the posterior capsule in the anterior vitreous, and once you try to fish it out, then there will be a lot of traction it is going to exert at the vitreous base, which may lead to complications. If not immediately, but over a period of 1 year, 2 years, the patient may land up with the retinal detachment or retinal tear. Similarly, if the IOL, you should never try to pull out a dropping IOL if it has gone deep, because the haptic, they are enmeshed with the vitreous which is there at the vitreous base. And never hope that if your capsule is not intact, if your sulcus is not intact, never hope that IOL will stay there with your prayers, because it will actually need a capsular support. And always remember that the very best you can do to your patient is on the operating table. So as the current discussion was going on, simulators now they are available, and they should be used by all the residents wherever the facilities are available, or now there are centers in the country which train you on these simulators. Even if the simulators are not available, then these practice eyes, sometimes your iBank eyes, they could be used. And now there is no dearth of videos and books which actually teach you in a very lucid way, in a step-by-step manner. So it is the effort from the trainee side which will actually bring good results. And whenever when we start our training, we should be very, very active assistants, so that the day when we have to do those steps, we are able to do them flawlessly. These are certain, I'll just take you through these simple cases. This is one of a 30-year-old lady whom you see the intraocular lens that has actually popped out of the sulcus. So this lady, though optically, if you say optically, you can call it aphakia, because he ultimately has diminution of vision with diplopia because of that edge effect which is coming in the center of the pupil. So, but the intraocular lens is there. So in such cases, minor surgical procedures like just doing an optic capture, you can see this is day 1 post-op. She regains 6/6 vision by just doing a posterior capture and fixing this intraocular lens in the sulcus. So certain cases where you have intact sulcus, where you can do anterior vitrectomy, which can address the vitreous loss and other pathologies, where you feel that there is no vitreous traction and the lens can be implanted safely. In those situations of aphakia, you can go ahead with implanting a lens. And always remember that it is a general thinking that if you have more than 180 degree of sulcus support, then the lens will be stable, but you require inferior support, because the day one post-op the gravity starts acting, and then this lens will slowly keep on sinking down. So this is another case, a 40-year-old lady who has this zonular dehiscence, which is almost 3 clock hours. So initial surgery was planned with a CTR and the PC was intact. The IOL was a single piece IOL was implanted in the bag. However, this IOL almost after a month was unstable. It had slightly shifted downwards, and then in the second sitting the IOL was exchanged for a 3-piece IOL at some other center. But after a month again the IOL has, you can see it has shifted up this times. So when this patient came to us, we really thought of possibilities that maybe the white to white is more in this patient, but that was not grossly abnormal. Then we thought of fibrosis of the capsule, because this ZD could be because of trauma, and at that point either the lens or the CTR is not sitting properly, or the CTR, one of the end of the CTR is not in the bag. That was a policy, the possibility we thought. So now one of the options for this patient was to explant this intraocular lens along with the CTR and do a glued IOL, or other option was to do a minimally invasive procedure of preserving the bag with the CTR, because if you are going to do a glued IOL in this patient, then you need to explant that CTR and it will be slightly difficult and it will be more manipulative. So in this patient also we thought of creating a posterior capsular rent to capture this optic of the IOL, and this is the same patient where you can see a 23 gauge needle is being used by just retracting this lens to one side and local vitrectomy to remove any traction, and you can see this is end of the case. And this is post-op day 1, where you can see the intraocular lens is very well centered without any angulations. So as sir was just talking about intraop OCT, we are very lucky to have this cutting edge technology in our microscope. So in this scenario, because if this case is actually predisposes for capsular rent, nucleus drop and aphakia, so in such patients to begin with I do a OCT of the posterior capsule. Here I am not very sure of the integrity of the capsule, though it may look to you that it is a smooth surface posteriorly, but there could be some place where the capsule could be there but it could be abnormal or very thin. So I do all the steps which are done in a posterior polar cataract, like avoiding a hydrodissection, and during the surgery also, once the nucleus is out, I am continuously monitoring this posterior capsule with the help of the OCT of the segment. And once my bag is clear, I again do a OCT here, and here I am almost sure that the posterior capsule is intact. So I become greedy and I go ahead with posterior capsular polishing, and here with just touching the posterior capsule it just opens up. So in this situation also, as I told, that you reassess, you do not do any manipulation without stabilizing the anterior chamber. So your second hand should have heel on so that you stabilize this bag, reassess the situation, and then slowly come out and do next action which is required. This is under high magnification that I was just trying to remove this plaque and this capsule has just opened. So again confirmed it on the anterior segment OCT, and there was no breach in the anterior hyaloid, there was no vitreous, so a 3-piece intraocular lens could be implanted in the bag. This is another case, a resident case. While operating, doing IA, there is a zonular dehiscence inferiorly and a big posterior capsular rent. So in this case, implanting a CTR sometimes could be challenging and counterproductive. So also there is some drop of cortical matter posteriorly, so I take up the patient, I do a thorough vitrectomy. Also, since I have this tool, so I do a intra-op OCT, and then with the help of cutter we remove any remnants of cortical matter, and then we remove the whole capsular bag complex, and then we go ahead with implanting a three-piece lens. These are the steps. There are some modifications I follow in my techniques, wherein I use these vicryl loops to just stabilize the haptic of the lens, then because I do not require an assistant if I use this vicryl loop. And here I am using a laser probe just to create the flange, and this is at the end of the surgery. And then you can see post-operative, the orientation and centration of lens is almost like a phacoemulsification. So even residents, despite of their due diligence, if they create any complication, they should not lose their heart. These cases can be well managed if they are taken up at a proper time. So another question is, when should you manage these patients, and when you should refer? So definitely when there is a lens drop or IOL drop, you should refer such patients. And if there is vitreous which anterior vitrectomy cannot handle, such patients should be actually handled by a vitreoretinal surgeon. And if there are any retinal lesions, then definitely they should be referred. And one thing is that we should never mix ego and vitreous, that we are shifting this patient or referring this patient, because ultimately then it is counterproductive for the patient. So coming on to these were the simpler cases which can be done without much intervention. So now the ACIOLs and iris claw lenses, nowadays ACIOLs I think are hardly used. I don't have very varied experience with anterior chamber IOL, because now these techniques of SF IOL, they are so good, and the lenses which are used are commonly available. Of late, mostly among anterior segment surgeons, is use of these iris claw lenses, where they can be used if the vitreous is properly handled. But as my personal experience, I have over a period of time, I have seen at least 2 retinal detachments in such patients, and 1 case with a dropped claw lens. So the key in using claw lenses or managing these patients with aphakia because of surgical complications is managing the vitreous. So sutured SF IOLs for a surgeon like me who has been who is not that old, who has not handled sutures so well. So I find it technically demanding, because you have a very thin 11-0 Prolene suture, and for the patient also there could be suture disintegration, not exposure, IOL tilt. So sutured SF IOLs are not very popular these days, because the main problem is that over a period of time, when there is suture erosion and only one side of suture is eroded, then it's very difficult to fix those lenses. So now most of the centers, they follow intrascleral haptic fixation techniques, and the results are much better as compared to the sutured ones. So the technique which was given by Dr. Amar Agrawal, which was known as glued IOL, so the advantage is, as I told, it can avoid hassles of suture. The foldable lens can be used, so the incision is smaller, and refixation or explantation is easier. However, now because of various techniques, the earlier technique, the classical technique, there are chances of dislocation with trauma, as we know that during trauma, if it is a blunt injury, then there will be equatorial expansion, and sometimes the haptics may get dislodged. For a beginning surgeon, the challenging steps which I found personally for myself, and I've seen most of the fellows under training, so taking out those haptics and tucking of haptics into scleral tunnel in the conventional technique are 2 steps to be mastered, and we do not require other fancy equipment, but we require this 23 gauge needle and a micro vitreoretinal forceps and glue to glue these flaps. So again, like in Phaco, we require a proper planning of the case under appropriate anesthesia. Marking of cornea is very important to maintain the centration of the lens, and I generally prefer in making 2 scleral flaps which are not exactly at 3 and 9 meridian, they are slightly off 3 and 9 to avoid any important vascular bundle. and then these flaps, the ports under these flaps can be used for combined procedure like a PPL or IOL explant, and then I'll show in the video that how this IOL is injected. So in the planning, any scars in the incision site, because most of these cases are post trauma or post cataract surgery, so we have to plan our incision as per the pre-existing scars. Also, it is important to look for any pupil abnormalities because it may lead to diplopia. Suppose a patient who has undergone SICS, he has got a superior dialysis. So whether we want to combine repair of that dialysis with this surgery, that needs to be looked upon. And some of the cases they have iris loss, but the capsular remnants are there, so we may use those capsular remnants as sort of iris segment so that we can avoid diplopia. And for beginning surgeons, always there should be IOL standby, like we were talking about ICLs. Otherwise then you will have to postpone that surgery. And white to white, it is good to look for any extremes like more than 13 or less than 9. And in children, if you are planning these surgery, then amblyopia management is equally important as in pediatric surgery. So this is the technique wherein you start with marking your cornea. This is slightly off 3 and 9, and then you do local peritomy, from where you will make these scleral flaps. You mark 2 millimeters from this point, and then these flaps are quite easy to master because they are like SICS flaps. And the only important tip here is that you should not hold these flaps with the help of some forceps, because otherwise you can end up with the amputation of these flaps. Then we put a AC maintainer, and then you make a perpendicular entry so that your cutter and light can go inside. So this is a case wherein we have an intraocular lens inside, and you can see that despite of these manipulations, this intraocular lens is not falling into the vitreous because the haptic of this lens is buried in the vitreous, which is at the vitreous base. So if you try to pull this, it is going to pull the retina with it, and it will create a big tear in the retina. So now we remove any remnant of capsule, and then we pick up this lens initially with the vacuum, and then the micro forceps which goes through these subscleral flap location, and then one of the haptics is out. Now in this technique, the assistance is required to hold this haptic till the other one comes out. So in this manipulation, sometimes they can get bent, and then you just secure them in these scleral tunnels, and you hydrate the port which you have made for the AC maintainer, and then they can be secured. So if you look at complications, haptic breakage is one of the most complication because you are doing these manipulations where the space is limited. So whenever you are coming out, you have to follow the curve of the globe, because the scleral flaps, they are 23 gauge, so sometimes can lead to hypotony, vitreous hemorrhage, hyphema, and this pupillary capture. So this pupillary capture, especially we did a study on children wherein a peripheral iridectomy prevents these iris related complications. So in every case we do a peripheral iridectomy with the help of a cutter. When I joined my fellowship at LV Prasad Eye Institute, I started doing these cases. So I kept a log of my cases, and later on it came as a publication wherein you can see compared to the consultant, except the time taken, which is part of the learning curve, other outcomes were almost comparable. So after this era of glued IOLs came Dr. Shin Yamane from Japan. He started this technique of flange intraocular lenses with a double needle technique. So in this technique, primarily you do not use a forceps, you use a needle to take out the haptic of the intraocular lens, and then you can flange the ends so that it remains in the subconjunctival space. And there is no need to make flaps also in the original technique. However, it has got certain disadvantages because you are going transconjunctival, transscleral into the vitreous cavity. So sometimes there could be that communication which remains. So now it has been reported that there could be chances of endophthalmitis or flange exposure. So to overcome this, we modified this technique wherein to avoid this problem of flange exposure, we made two scleral pockets instead of the flaps which we used to make in the traditional technique. Here we made two scleral pockets, and it was COVID time, so fibrin glue had the availability was not very good. So in some of these cases we tried autologous blood to fix the conjunctiva, and this technique we found more replicable and predictive. So this was published as a surgical technique wherein the cornea is marked in the same way as a glued IOL, and then we make these two marks, 2 millimeters and 2 millimeters, according to the haptic of the IOL which we are going to exteriorize. And then instead of a flap, here we just make a scleral tunnel, scleral pocket, and the aim of this pocket is just to house the haptic which will be coming out from inside. So we use a needle, we inject the intraocular lens inside, the haptic is resting on the iris, and then we put a needle through this scleral tunnel, and then the haptic can be exteriorized outside, and then it can be flanged. This is the heat cautery which is being used. And finally, now because we do not have any scleral flaps, we just have a tunnel which will be self-sealing like a SICS tunnel. So we actually do not require fibrin glue, we just require some technique to close this conjunctiva, and even you can use a heat cautery, you can use autologous blood. So this is just a short video of the technique. So this 2 millimeters is marked, and then this is the lamellar scleral tunnel which we have made. This is the anterior chamber Mentera. You can even use a vitrectomy trocar cannula system. So this patient, there was some vitreoretinal procedure to be done, and then we insert this intraocular lens, and beneath this scleral flap you can pass this 26 gauge needle, and with the help of this vitreous forceps you can just exteriorize this haptic. And then you can just flange it and leave it there. Same thing is repeated the other side, and once the haptic is out, you can adjust the centration of the lens, and then there is already a pool of blood this side, so this conjunctiva can be easily closed. And this side we found that this blood is not very fresh, so we just puncture a conjunctival vessel, we create a pool, and after some time you can just iron out this conjunctiva. In certain patients, like wherein you have they are on antiplatelets or some other coagulation blood thinners, in those patients you may have an issue, and you can use a fibrin glue or a heat cautery. And this is this first day post-op day. You cannot actually make out whether it's a Phaco or a glued IOL. The intraocular lens is very well centers, and the conjunctiva is well opposed. So this was presented as an innovation at various forums, but we didn't stop at this innovation. Sometimes what used to happen that the flanged haptic of the intraocular lens used to retract inside when you are manipulating from the other side. So to avoid this retraction, we now routinely use these vicryl loops, so that once the intraocular lens haptic is out, you can actually tighten these sutures, so that you do not require assistance to actually hold these sutures. So the purpose of these sutures is just to hold the haptic securely, and then you can flange it, and also at the end of the surgery you can just push this cut end of the sutures inside. It's like a additional security which you are buying for yourself, so that the haptic does not actually go inside.
As the haptic comes out, and
so it goes inside. So as compared to Dr. Shinyamani's technique, you can see here that it is very well buried under the sclera. All those chances of haptic exposure, end off, all those things are not there. So here also we are using the finger, and you can see the results, they are equally good. So with this technique we published another study, and we used heme plug imaging for intraocular lens position in this technique, and we found that the tilt is minimal. It is comparable to cases of phacoemulsification, and the key here is to do accurate measurement, so that the intraocular lens from where it is exiting is exactly similar on both the sides. So sometimes you would have heard about Wing Commander Abhinandan. He belongs to the Indian Air Force, and during the surgical strike he got one F-16, which is one of the very advanced fighter aircraft, down with his old MiG. So similarly, sometimes we may be the resources may be limited, so we need to innovate and do various technique for benefit of the patient. Like this patient, we do not have a three-piece lens, so we are implanting SF IOL in this lady, scleral fixated IOL, the traditional one with sutures but without knots. So I'll just run through it. So here what we have done is that we have passed a needle from here, and then we are passing a 50 Prolene suture which will exit from here, and then we will pass it through the other eyelet of the SF IOL. See, it has been passed from the other side, and both sides the suture has been flanged, and once the intraocular lens is in place, then here you can see that the end of the suture has been cut. So there are virtually no sutures, and this is the outcome. The intraocular lens is very well centered, and the vision on the follow-up was well maintained. So to conclude, multiple options are available for management of aphakia, but we should understand that all these techniques are evolving, and choice of technique is based on condition of the eye. We should always do a thorough clinical examination before the surgery, associated ocular features, whether how is the pupil size, iris defects, aniridia, and previous surgical scars, and also wide to wide diameter, because I remember of a case wherein one glued IOL with traditional technique was done 2-3 times, and then ultimately we had to fix that lens in a vertical meridian because horizontal wide to wide was much more, and also technique as per surgeon's expertise. Just a word about what is there in the future. Now I just came across a study wherein now there is a device known as VAMA device, which is like a implantable capsular bag. So these are the sutures through which it can be fixed inside the eye, and then you can implant the lens of your choice, maybe toric lens or multifocal lens, because in glued IOL you have a limitation of using a unifocal lens. That's all from my side. Thank you very much.
Satish, wonderful presentation. So before the PG questions start, I want to ask you if you would mention which lenses do you prefer with no financial interest declared?
Yeah, I use Alcon lenses, ma'am, 3-piece lenses.
Do you find that flanging and both manipulation are easy and it's never led to
Ma'am,
broken
actually,
haptics?
most of the people think that the 3-piece lens has got blue haptic, so it is made of Prolene. But I also used to believe it for quite long time. But then it is actually made up of PMMA, so it is very fragile. So it may sometimes break. So 2-3 things I have seen that sometimes our operating rooms, the temperature is quite low. So one is slightly pre-warming those lenses. The chances of haptic breakage are less. Another thing, whatever manipulations we are doing, we have to be mindful of this complication, because if you pull the lens out without following the curve of the globe sometimes, and sometimes even the needle can cut through these haptics if undue force is applied. But maybe after my initial learning curve, it's a very long time now that I had a haptic breakage. Initially it used to happen, the haptic used to cut, and lots of problems used to happen. But following the curve of the globe and being mindful of the sutures and holding the force which you are applying, that actually creates difference.
Dr. Avdesh.
Do you see tilts in
Yes,
the vertical and horizontal axis?
ma'am.
Horizontal and vertical tilts often we see in some cases.
Yes, ma'am.
You can declare horizontal and vertical tilts. How would you handle it?
Yes, ma'am. So the one thing wherein you are using a technique wherein you are dissecting the conjunctiva and you are exposing the sclera, and you are doing proper marking as you do for a toric intraocular lens. So if you do the exact accurate measurements on accurate axis, then I don't find there should be any reason for this intraocular lens to tilt. But if you do techniques like classically described by Shin Yamane, wherein you are going transconjunctival, you do not know, which point in the sclera you are actually entering. You are making some measurement on the conjunctiva, and based on that you are entering on the sclera. So I find those cases they would have more tilt. Otherwise, in gluteal, if you expose the sclera and mark your points properly on the axis, then the tilt should be minimal now.
Lovely videos. Dr. Nepalia, please.
Dr. Avdesh,
Sir.
compliments to you for a very wonderful, presentation on management of aphakia. For the sake of my knowledge, I wanted to know whether you are a anterior and posterior segment surgeon both.
That's a good question, sir. Actually, I work in the Indian Air Force, so I am a graduate of Armed Forces Medical College. So
Yes,
what
in
happens
Pune.
that initial 5, 6, 8 years we are hardcore cataract surgeons, sir. We dream, we work, we do everything for the cataract, and then
Right.
there is a very stringent selection criteria. Maybe out of in 3, 4, 5 years somehow you are selected for what we call a study leave, and then we are given 2 years of leave. So I was one of those lucky people. Then I went to L.V. Prasad Institute and I did vitreoretina, sir. So both.
Compliment for that. Compliment for that.
Thank you.
I would have just appreciated if in your initial talk you must have just narrated few points about signs of aphakia for the sake of resident doctors like deep chamber, jet black
Understood.
pupil, presence of
Hydrolysis.
PVI, suture marks, and all
Ah,
that,
correct.
absence of third and fourth Purkinje images. I ditto your comment that watching videos is the best modality to learn more and more about secondary IOL, because
Yes.
secondary IOL is a very tough challenge for any ophthalmologist.
Yes.
What do you do to prevent post-operative decentering of IOL while putting it in the sulcus? How to
Sir,
ensure? Because you have mentioned in your talk that sometimes there may be a little problem for the stability of the IOL.
sir.
So any particular thing in your mind to overcome this post-op
Sir,
problem?
yeah, if it is feasible and if it can be done, if the rent is not very large or not very eccentric, then I have found that posterior capture of the optic is a very good technique wherein you can ensure long-term stability of the intraocular lenses. Another thing, sir, is that we have to have a good inferior support, because when the
Yes,
patient, yes,
that
when
was
the
the point.
yes,
Yes.
when the patient starts sitting, standing, then invariably we will find that sometimes even more than 180-degree sulcus is intact. But if it is not intact inferiorly, then the intraocular lens will not be stable. And also the orientation of the haptics which you do in various situations of using CTR, not using CTR, they are very important, sir.
I thought that was a very important point you have highlighted.
Yes, sir.
Then why you are not in favor of retro iris claw implant? They have lately become very popular. Do you feel rejected by two post-op RDs and one post-op iris claw drop lens that you don't go for that at all?
No, sir. You have a very
Because
valid point.
nowadays these iris retro iris claw lenses have become very popular and they are giving good results in the
Yes,
hands of many surgeons all over the country.
sir. So only one thing, sir, why I am not in favor. Actually, during my very early residency, earlier we used to have some American Academy videos, sir. They were the only videos which were available. So
Oh,
once I happened to see a video wherein the American Academy actually describes that why you should not do sponge vitrectomy, which earlier used to be done with the venas. So in that
okay.
demonstration, sir, even a slightest movement of the sponge was actually pulling in a very quantum way at the vitreous base. So what I feel now as a vitreoretinal surgeon, that whenever you are handling the vitreous, then we have to be very, very respectful to that vitreous, which may cause break and tears at the periphery, sir. That is the only point. So I'm not
So,
a great
so
fan.
this holds true for you, that what fear complex you develop in your childhood, it carries on throughout, isn't it? And last query, why there is a greater risk of rise in post-op IOP in all types of secondary IOL?
Sir, one to those standard causes because of inflammation, because you are handling the iris. Then there could be rise in intraocular pressure. Sometimes you do not wash the visco, it goes posteriorly, and later on you can have then the steroid response, which will be there maybe after a week or so. But most commonly, sometimes if you do not do a proper PI, then because of the pupillary block, also those patients they may go into high IOP.
I think that was the most important point you have touched now.
Yes.
That most of the time in any kind of secondary IOL, if we do a small PVI or even
Hmm.
post-op, if we do a a PI,
Yes.
it can serve a great purpose in preventing rise in post-operative intraocular pressure.
Yes.
So you are happy with modified flange IOL?
Yes, you're very
Uh,
happy, sir.
uh, how would you recommend to our younger these lenses to our younger generation?
Sir, younger generation, it has got a very, once you understand the surgery, the learning curve is not very steep. The only thing is that haptic breakage and those initial 10 cases maybe that would be the learning curve. Otherwise, it is a very wonderful surgery as good as phacoemulsification, what I have found, sir.
Compliments to you.
Thank you so much, sir.
We had a wonderful session, I think, and thanks to all the speakers, Dr. Preeti, Dr. Indu Pandey, Dr. Aishwarya, and Dr. Avadish. Fantastic presentations from all of you, and I thank the expert panelists for the active interaction. Dr. Nepalia has been very proactive in focusing on the PG's question and answers, and also Dr. Vandana, she couldn't stay till the end, Dr. Rajesh and Dr. Rajan. So I thank everybody and wish you a wonderful weekend ahead.
Before we depart, a special word of thanks to our chairman, Dr. Samar Kumar Basak, to our moderator, Dr. Puranik, and to our program directors, Dr. Santosh Shavnar and Manoj Mathur, for giving us a chance to join this wonderful scientific program. Our compliments to all of you. Thank you once again.
Thank you, sir.
Thank you, sir.
Thank you.